Good morning, Dr. Chabot.
Good morning.
Comment ça va?
Je m'excuse, Anne-Sophie, je t'ai pas entendu.
Mais pas de problème, je me demandais comment ça va, puis si vous vouliez essayer la présentation de partager
Oui.
l'écran au début.
Oui. Hey, attends, je vais essayer de me trouver un background où c'est que vous voyez pas mon bordel parce que je suis en déménagement chez nous. C'est genre...
Ah, c'est excitant quand même?
Oui, non, c'est très cool. C'est juste beaucoup de travail en plein milieu d'une pandémie et tout, tu sais, c'est comme pas le meilleur des
Oh mon
moments.
Dieu. Moi, ça s'en vient au mois de mars, là, ça va être la même chose. Je suis comme...
Tu penses, toi, qu'on va avoir une autre vague?
Non, mon déménagement,
ton
mais je sais même pas
déménagement,
encore où je déménage. I'm
j'étais...
being kicked out. Oui, non, quoi? Il y a quelque chose d'autre qui s'en vient?
Oui, là, j'étais comme pas une autre vague. Oui, attends, j'essaie la présentation, ça sera pas long. Hey, je pense que je vais faire mon fond d'écran flou. Je pense que c'est ça. Je pense que j'aurai pas le choix. Mon bureau, il n'est pas assez présentable.
Mais ça marche mal quand c'est pas un fond complètement blanc, là.
Non, ben le flou, il n'est pas si pire. Attends, on va essayer. Ça, c'est pas pire? Pas pire.
Ah, c'est bon, ça. Parfait. Là, on voit les notes de présentateur.
Parfait. Fait que là, comme ça marche?
Exactement.
Parfait.
Moi, est-ce que je suis quand même capable de voir? Je vais envoyer un lien. Je pense qu'on va avoir un bon turnout ce matin. On a plusieurs bons invités.
C'est bon.
On va peut-être juste... Je vais voir combien ça prend de temps avant que les gens se login, là, mais je vais peut-être laisser un petit...
Il n'y a pas de problème.
4 minutes de buffer, là.
Parce qu'en fait, nous autres, ce qu'on a préparé, c'est 3 cas qui sont très typiques de la gériatrie, là, à l'urgence. Puis, on a prévu, tu sais, 5 minutes urgence, 5 minutes gériatrie, puis après, discussion avec tout le monde, là. Fait que, tu sais, on va espérer que ça soit un peu interactif, même si on est sur Zoom, là.
Ça marche bien d'habitude.
Oui.
Fait qu'on va se laisser quelques minutes. Puis
Pas de problème.
Good morning, Dr. Reid.
Good morning. Morning, everyone.
We're just going to give a few minutes for people to log in. I usually leave until like 8:03, 8:04, then we'll get started.
Yep. I'm just waking up. Give me time. That's good.
Exactly like we planned it. Giving you time to wake
Julia's been practicing since 6:30. She's got an unfair advantage. Her younger kids wake her up. That's the problem.
That's what happens when you have a 4- and 2-year-old at home.
A lot of things happen when you have a 4- and 2-year-old at home, I feel.
A lot of unexpected things also. It's amazing the types of, it's amazing.
In a pandemic, when they're always at home.
In COVID isolation, because there was a COVID positive case at the daycare.
Your life must be so easy right now. Honestly, we really appreciate you being here. It's a particular context. Okay, so I suggest that we start now because we usually start at 8:30. So people will be joining us in a few minutes and I'll just let them in the room as they come. Would that be okay with all of you? So welcome to the first round of the year. We're quite excited about the lineup we have today. And we're very excited to hear our two speakers for the never-ending debate between Jerry and ED. So let's see.
Thank you very much, Anne-Sophie. So good morning, everybody. So I'm going to be presenting today with Dr. Reid that everybody knows, and I'm Dr. Chabot. I only put my name over here. I'm sorry, Andrew.
You're starting the mind tricks already, eh? You're playing the mind games, leaving me off of the title page. That's great, Julia. That's great.
It's a real honest mistake, to be honest. I'm really sorry. But so it's funny. I was looking at the chat and I saw that Dr. Nemeth is excited about a debate. So actually, I took this idea from a couple of of years ago at the Canadian Geriatric Society, where we actually organized a similar debate. And obviously in the eMERGE, there's a lot of geriatric patients, and there's often a lot of, I wouldn't say confrontation, but sometimes different points of views in how to manage those geriatric patients. So the goal today is that we will basically have 3 very bread and butter cases of geriatric patients in the emergency room. We're going to try to present both the eMERGE and the geriatric perspective. And after every case, we'll leave a little bit of time for a discussion. So our first case, if my computer allows me, so it's basically an 88-year-old lady who comes in with a fall, known AFib, hypertension, CKD. These are her medications. So you can see that she's anticoagulated. She's on Ramipril, takes a sleeping pill, and on metoprolol. Lives alone, walks with a cane, and comes in, as I said, because of the fall. She says she remembers the entire event. She said she didn't lose consciousness. She did not hit her head, didn't have any chest pain, palpitation, shortness of breath, or any prodrome. She also reports that she falls often. Her physical examination, I mean, her vitals are stable. She has an irregular heart rate and some ecchymosis. So I will let Dr. Reid get started on his eMERGE perspective.
So thanks, Julia. First of all, if Joe is right that the first rule of being good at debate is being menacing, then I'm not sure if you're going to get great debate from Julia and I, and we'd have to work on the menacing part of our personalities, but we'll do our best to be a little bit entertaining at 8 in the morning otherwise. And my job here today is not going to be presenting you with too much teaching. It's just a little bit of ER perspective, and then to let Julia get into some real GRA teaching, which I think is the most important part of the talk for today. So case 1. So obviously we see this kind of patient a lot, as Julia mentioned. And our first job when we have an elderly patient who is anticoagulated and is having not just a fall today, but multiple falls recently, is 1, to make sure there's no traumatic injuries, and 2, to really get at the etiology of these falls. She seems to be hinting at tripping over something, but we have to keep in mind that that might be the etiology for this fall, but we've got to think about all the previous ones that have been happening too, and could there be a different etiology? And then ultimately we're going to have to determine if this lady is safe for discharge, and we'll talk about a few different things we can do that might help us with that. So as far as the traumatic injuries, I don't think anyone's going to argue that we need to do a CT head on this lady. She's old, she fell, she is anticoagulated with dabigatran. So we're going to go ahead and get a CT head, not just for the fall that she's had today, even if she says she doesn't hit her head, doesn't have any necessarily signs of external trauma. She's getting the CT head also partly because she's been falling a lot recently. There could be a chronic subdural or something like that that's making her a bit off in terms of her balance and mobility. So the CT head's a no-brainer. C-spine, I think most of us would probably do it. I'm trying to be a bit more thoughtful about CT C-spines, and people who have no pain and give a good history and are able to move their neck. But at her age, I think if there's any doubt, C-spine rules or not, she's going to get imaging of her C-spine as well. And of course, based on any pain she may have elsewhere, we'll order x-rays as needed in terms of just finishing up the workup to rule out any traumatic injuries. Go ahead, next slide. And as far as the etiology, we want to know why, not only again thinking about just this fall, but all of these recent falls, what could be actually causing this. Often it's multifactorial, but we want to see if there's anything obvious from a medical point of view that might be causing it. So we're going to get our typical workup that is not really all that challenging for most of you guys. We'll get an EKG, get some labs. We're going to certainly want to try to corroborate this history. It sounds like she's for the most part trustworthy, but we want to go into the falls beforehand, not just the one today, and ideally see if we can corroborate with any family members, people who live with her. I think she lives alone, but see if there's anyone else we can talk to. We want to make sure that we see how she's walking. She says she walks with a cane. Maybe we try her with a walker. I think that could be maybe a key to possibly discharge this lady if she doesn't have any major medical issues or traumatic injuries. She might just need a bit more support, and that might make a big difference for her. And we're going to try to look at her meds. Certainly there's, I'm no geriatrician, but I know we often get a bit concerned with anticoagulation in people who are having multiple falls. She's got advanced renal disease, so that can affect the dosing of some medications. And I don't like this issue of the sleeping pill. I'd like to get a bit more info on that, whether it's through DSQ or calling her pharmacy to see if that's something we should stop, because it might be contributing to her falls. Go ahead, Julia, next one.
Perfect, yeah. And I think somebody is asking that they would like to know which labs you would
Sure.
want to order.
Sure. I mean, I'm open to seeing in the chat what people would get, but I mean, at a bare minimum, I'm getting a CBC SMA7. If I think that there's any chance that this wasn't a mechanical fall, I'd be doing a trope. I think most people would have a pretty low threshold to do at least one trope, depending on the time of this fall today. Plus, consider if any of these recent ones might have been more syncopal or cardiac events. Extended lights, if you're thinking about arrhythmias and possible syncopes as a cause for the other falls. Probably you could debate whether you want to get urine analysis and urine culture. Doesn't sound like it would be contributing here, but I think a lot of people would do that as well. That would probably be the limit there, unless there's something that I'm completely forgetting. So if all that stuff comes back essentially negative, then we've got a question of whether this lady who's 92 and living alone, anticoagulated, if she's good to go home. And I would consider, before just doing it on my own, possibly getting some help. I don't know if I would go towards a full-on Geri, physio, OT, getting the whole team involved. It sounds like mostly a mobility issue. So I would probably get physio to see this lady. Partly because I know that's the easiest way to get a walker for someone. So I would get physio, and if they feel that this patient is walking better with a walker and is at her baseline, and the patient wants to go home, that's the key thing. If the patient looks safe right now and wants to go home and is willing to use a walker, then I think she would probably be okay to be discharged in relatively short order. Again, assuming that all of this workup is negative and all the basic stuff that, you know, is not always the reality, but you hope that she's got good family doctor follow-up that could look at these meds. I would probably consider, if she is going home, sending a letter to the family doctor to consider looking at some of these medications again, and just to make sure that they're aware of these falls, to try to close the loop on the outside. But that I think this is someone that, again, if all these things line up in a row, that this patient could go home without seeing geriatrics.
Perfect. Thank you, Andrew. So now I want to show you what we could actually do in geriatrics. That could be a little bit different. I think my main goal with this patient over here is to avoid her coming back to the emergency room. So we already said that this is a patient who falls off very, very often. So it's not a first fall, it's not a sentinel fall as we call it. So my goal is really to bring this kind of multidisciplinary approach and a multi-systematic approach so that I can prevent yet another fall and hopefully another injury in this patient. So I'm sure that all of you have heard of the geriatric 5Ms. I'm just going to go quickly over the 5Ms for this case. I like the 5Ms because I think it gives a nice structure on how to approach those geriatric patients. But sometimes it's a bit redundant, but just to give you a bit of an idea. So my first M is I would challenge the mind, in the sense that, yes, the patient is reporting that she didn't lose consciousness and that there was no head trauma. Well, Andrew said that he would order a CT head, so I'm very happy about that. But my big question over here is my story even reliable? Is this patient completely cognitively normal, even if she looks like she's with it? And ideally, we would need to get some collateral information. And I wanted to give you a few tricks and obviously I can't, I mean, I really don't see the same volume of patients as you guys see in the Emerge every day, obviously. And I can't, but even if I see just a few consults in a day, I still don't have enough time to do an MMSC on every single patient. So I can definitely imagine that there's no way you guys will be able to do that. However, there's a few little tricks sometimes that I can give you. So this is an MMSC over here. There's a couple of key questions that could be asked. So basic orientation question. I know that we're good with the alert and oriented ×3 in the Emerge, but sometimes you can try to push it a little bit. So do they know which country, which town, which hospital they're in? Well, mind you, sometimes they don't even know which hospital the Urgence Santé brought them in. But those little questions sometimes can be very nice. And the thing that I really like to do is the registration. So I check the recall basically. So the 3 words, I'm going to tell you 3 words. Can you repeat the 3 words after me? And try to remember those 3 words, because I will ask you again later. And as I take my HPI or as I do my physical exam on the patient, 1 or 2 minutes later, I will ask them again. And then if I see that they have a 0 or a 1 out of 3, it's already giving me a cue that maybe there's something that's going on. The other issue is that, and I'm very happy because Andrew mentioned both the bigatran as well as the sleeping pill. But the other thing that I want to bring to your attention is that her pulse was a bit, Andrew said he wouldn't remember the 3 words. We should check your attention, Andrew. But basically her pulse is a bit on the low side. So one of my question would be, could it have been, it's a recurrent fall. Is her dose of metoprolol too high? She's 62 right now. She's a bit borderline. What about the sleeping pill? What is that sleeping pill? I mean, you guys all know about the fact that we should not use benzodiazepine in the geriatric patients. So I would try to see that. And it's not rare that I actually will discharge patients on a very, very slow taper from the emergency room. The other thing is I would also check for orthostatic hypotension. It takes just I mean, it's very, very simple to do. And that could make me reassess my ramipril. And the last point I wanted to bring, so Andrew mentioned the borderline EGFR, which I'm very happy about, because probably not the best medication choice, that particular DOAC in that patient. We know apixaban is probably the safest of the DOAC in the geriatric patients population. But the other thing I also wanted to bring is I often get this question in the eMERGE about what about falls and anticoagulation. So I'm bringing you back to a very, very old study. I think it's 99, if I'm not mistaken. It's very old. But I really like this study because it was done with, I mean, it was warfarin at the time. We didn't have the DOACs. But basically, we know that somebody who was taking warfarin would probably have to fall close to 300 times a year for the warfarin not to be the optimal therapy. And this is just looking at subdural hematoma. So it's giving us a lot of information that in my head, to be honest, you really, really have to fall very, very often. I'll be very honest with you. If this patient is really falling 4 to 5 times a week, she's very getting close to probably not being unsafe on anticoagulation. But then the other question is there something reversible I can do over here? In terms of mobility, so recurrent fall, I would question, is the cane appropriate? I would like to get her seen by physiotherapy. Maybe a walker would be more appropriate. And again, I'm going back to the check OH, check for the sleeping pill. Sometimes we forget about vision and hearing. Probably not much we can do in the eMERGE, but if there's a family, just telling them like maybe get the eyes checked, maybe they need to change the glasses or something like that. And also thinking maybe they need an OT assessment at home. She tripped over something, so maybe we need to liaise her with the CLSA. This is just a study showing you that it's one of those landmark trials for us in geriatrics, that gait speed and survival in older adults. So it's just to give you an idea that if you see a patient who walks very, very slowly, we know that their mortality is much higher. So it's a very simple measure, but just the gait speed and just looking at the way a patient walks gives you actually tons of information. The other thing I wanted to bring up about falls is we think about all of the causes of falls, but don't forget that dementia or major neurocognitive disorder is one of the biggest risk factors for falls. So that's why I'm going back to my first M of saying that's why it's so important. And that's from the JAMA clinical examination series, but the likelihood ratios of fall with dementia is 17. It's super high. The multi-comorbidities over here, AFib, hypertension, CKD, look pretty stable at this point. There's no medical instability. But the last thing that I would explore with the patient is what matters most to her. So what is she hoping? How does she want to go home? What is she basically expecting from this eMERGE visit? So hopefully by getting us involved, I think one of the things that would help is that hopefully we would be able to prevent yet another fall from happening instead of just discharging her from the eMERGE. So I don't know if there's any comments or if anybody has has anything to add. This is just a reminder of the discussion, the case that we just discussed about. So I'm opening up the floor.
Well, thank you to both for this first case. I think that's a very bread and butter for sure, as you announced it. Anybody wants to pitch in terms of what happens in, we have Mark Bake who wants to pitch in.
I'm sort of listening to this and, you know, I cannot disagree with either of the people presenting. My question though has to do with, this is all, I personally would get geriatrics involved in a case like this at the MUHC. They often have more comorbidities. The question always comes up, if it's 8 o'clock in the morning or 10 o'clock in the morning, weekdays, that's great. I got a multidisciplinary team available. They will see the patient during the day. By the end of the afternoon, you can be pretty sure that, you know, OT, PT, and geriatrics will have seen the patient, and CLC will be involved in that kind of stuff. The patient is nicely wrapped up. And, you know, the consequence of falls in that patient population is immense, both in terms of the patient, but in terms of our ability to have inpatient resources available. Once that patient falls and she breaks her hip or something like this, it's a complete disaster. So that's one thing. But the second thing is, that's about 30% of the working time of the emergency. The rest of the time, you have to keep the patient overnight, over the weekend, and that has its lot of morbidity and mortality, just the ER stay in itself. We have at the Glen private rooms in the emergency, so the stimulation is less, but even though it's even that, you know, by next morning, your patient can be delirious and need to be admitted just because you kept them overnight to be seen by geriatrics the next day. So I'd like to hear some thoughts about how you balance this out. Would you be better taking the patient home, bring him back the next day or the next working day for geriatrics? Is there a fast track to get these patients assessed within 48 hours or something like this? Because the stay in the emergency is a load on the unit itself and has consequences on the patient, which are beyond just getting a positive. There are lots of negatives associated with this.
No, I think that's an excellent point. I'm not sure exactly. I work at St. Mary's, so sometimes in those patients, it does happen that they get discharged in the evening and they come back the next day, especially if they're seen on the walk-in side. So we reassess them in the daytime instead of spending a night in the emerge. However, you're perfectly right. We've seen patients in the emerge that I see them in the morning and now they're delirious, and I speak with the family and they were not delirious the day before. So keeping them overnight probably did something even worse. One of the things we're working on in the Geri clinic is to have a fast track system, so that I think a patient like that, in a sense, if she's safe to go, and she was cleared by PT, for example, then the rest of the workup could potentially be done as an outpatient. I think that's an excellent point. Unfortunately, I don't have a perfect solution, but that's something that I would look into.
Yeah, I agree, Mark. It's a great point. And when I was preparing for all these cases, I always try in my mind to picture seeing them at 3 or 4 in the afternoon, because that's more often I find our reality in the emerge, and it puts us in a bit of a difficult position, because the decision is not easy. We know, as you said, that it can be disastrous for these elderly patients to spend too long in the emerge. But at the same time, you know, if someone really would benefit from a Geri consult, should they not get it because they present at a different hour of day? Like, should they be treated differently? It's a bit of a weird concept that we're constantly, I think, trying to juggle to give the best care that they need. That's why I do at St. Mary's like when people have enough support that they can go home overnight and come back to get the full team assessment, but that's not always the case. And you know, rarely they've got really closely following family docs that can get quick follow-up, but that's you know, it's nice when that happens, but it's sometimes we're a bit stuck in those situations.
Yeah, and actually I think just for time purposes, I'm going to move to the second case. And that's actually a very interesting discussion over here, because when I was preparing the case and I was speaking with Andrew, we said, well, this would be a perfect 8 o'clock consult in the morning, but if it's any other time, it's another completely it's much more challenging. So I'm sure you guys also see those types of patient, 89-year-old lady, a man brought in by his daughter. The daughter cannot manage anymore. She's pretty much alone. There's no other family support. Her mother passed away about 9 months ago. And since then, she's been taking care of her father, and she noticed he's very confused. He asked the same question, has some behavioral issues. He wanders at night. He needs to go to the bathroom, needs to be bathed. She basically brings him to the emerge, and she's hoping that he would be placed from there. So that's another bread and butter case that we get. So the couple of points I wanted to bring with this is actually some slides from the World Alzheimer's report, which by the way was done by McGill this year. And I mean, if you look worldwide, it's not the same in, hopefully we're a little bit better in our country, but 47% of people living with dementia have a lack of a trained clinician as a barrier to diagnosis. So it's difficult to diagnose those patients. 33% of clinicians don't think that there's anything that can be done about dementia also. And I think I missed that slide also, but 75% of dementia people are not diagnosed. So there's a lot of underdiagnosis. And at the same time, people with diagnosis, and at least, or sometimes their families or caregivers, think that they don't have enough support, so they don't have enough information about the diagnosis. So for that patient coming in and the daughter is completely burnt out, my first question would be, is this patient known to the CLSC? If no, of course, a referral will need to be made. And just so that you know, there are some services sometimes, and I know I am perfectly aware of how difficult it is sometimes for people to be on a waiting list in terms of having a social worker from the CLSC. But once they're in the system, sometimes there are programs that can really prevent caregiver burnout. So there's a program called Chèque Emploi Service. It's basically when the family can hire some help, and it's and the CLSC will pay a couple of hours. So for example, the CLSC may say, I'm going to finance this family for 24 hours of care per week, and the family can go and hire somebody. There's also the option of respite care. There's the option also of day centers that can be done. I also wanted to mention there's a new program that was created at McGill, the Dementia Education Program to support caregivers, and I put the information here on the side. But when you actually speak with caregivers, a lot of them will say, if I had known that this was because of dementia, if I had known that this was going to happen, things may have been different. So let's not underestimate how education can actually make a huge difference in those patients. There's also the Alzheimer's Society, which is a great, an incredible resource. One of the things that they mentioned on the website that I like is what to expect as the person's dementia progresses. And the last organism I wanted to mention, which I think, oops, sorry, I think not a lot of people know, even a lot of the geriatric residents don't even know about this organism, but it's l'appui pour les proches aidants. So it's basically it's a governmental funded organism, but they support tons of different community organisms across the whole province. What's very interesting is if you go on the website, first of all, you'll find out that there's a caregiver support line. So it's from 8 a.m. to 8 p.m. If the caregivers are burnt out, they can call that line. And sometimes they can provide education, they can link them with services, or they can just listen. Sometimes they just need to be listened to also. So that's a great resource to give to the patient. I mean, and here, who's the patient really? Is it really the patient, or is it the daughter? That's the other question. The other thing which is great is if you enter your postal code on that website, it will put you in, it will basically give you tons of information about community supports. So respite care, for example, there are respite centers that are not necessarily, that may be private in a sense, where the family may have to pay, but at least there is a service of respite care. They have transportation services, sometimes legal assistance, tax assistance. You know, they always have questions about, well, I get all the questions about the tax, the disability tax credits and things like that. So that's a great resource. So basically for me in that case, if we're getting consulted as a geriatric team, making a diagnosis of dementia. I mean, clearly here there's a diagnosis of dementia, and trying to educate the daughter. Sometimes it's a matter of setting expectations, and we actually may be able to discharge that patient from the emergency room with all of those resources in a clear and we close the loop basically with the CLSE. I'm not saying how easy that is, and I'll let Andrew give the give the emerge point of view for that.
So just quickly for this case, again, really a caregiver burnout case with the patient with the dementia that seems to be progressing. Essentially, we have two patients that I think are equally important. If anything, you could even argue that the daughter's perspective, or at least the history taking from her, is going to be more important, because she's going to give you everything that's happening with the father. And the key thing for me with the daughter is to really find out more of what she means when she says she cannot manage anymore, because that could be a big spectrum of things in my opinion. And we'll talk a little bit about that. But the other thing with the patient himself, and this can sometimes be done relatively quickly, is that we want to make sure there's no acute medical issue going on, and that there's no signs of elder abuse. I think that's something that we tend to gloss over a little bit. So we need to make sure we're doing a detailed history and physical to look at those two things. Next slide, Julia. So for the daughter herself, I mean, what does it really mean? And that has to be explored, because if she's truly cannot go home with this gentleman one more time, there's risk of suicide, risk of harm, or anything like that. Obviously, this patient's not going anywhere. We're going to consult geriatrics and be done with it. If it's more of a, I'm really having trouble, I don't see myself doing this in the long term unless there's more help, I'm incapable of doing this alone. But if you pursue that, and if you're able to get some things going, get them on a waiting list, give them some resources, maybe get a social worker involved, or someone to open up the case for the CLSC to do a full assessment at home and provide more support, then it could potentially be someone that could be discharged and not needing to be admitted to geriatrics. For sure, if you're not getting any of that, if you're really getting the sense that the daughter can't manage, this is not going to be an easy discharge. I would have a very low threshold to consult geriatrics. My question for them would be, let's just get this patient admitted though, get them on the floor where the rest of the stuff, all those time-consuming multidisciplinary stuff can be done. My experience, at least with these patients, is that they don't get discharged. It takes time to find them get the appropriate support set up, or eventually if they need placement. These are not things that happen overnight. So my goal with the geriatrics consult, especially if I'm putting it in at 3 or 4 in the afternoon, is let's just get this patient admitted so they can get a bed on the floor, and the rest of the workup can be done. That would be my goal. And if it was earlier in the day, and the geriatrician wanted also PT, OT, social work, whoever else to see them, I have no problem doing it. But I think the main goal here is let's just get this patient on the floor, because that's where things are going to happen a bit more at a pace that will be helpful for the patient and the daughter.
And if I could just add a point, because obviously we're talking about discharge planning and who do we admit, who do we not admit, or something. And sometimes even for us, if I have been able, a few of the very caregiver burnouts, we've actually been able to organize CLSC services from the emerge when all the stars are aligned. I agree, it's always a bit of a challenge, but sometimes, just so that sometimes if they are in the emergency room, it's a way for me to contact the CLSC and say, no, I'm not admitting. And it's almost a way to put pressure so that I can organize a much more rapid discharge plan. Because often the minute that they're in the hospital, and for us at St. Mary's, we have an admitting unit. So it's also very different from one milieu to the other. Not every hospital has necessarily that. But the minute I'm in the hospital, I kind of lose the pressure that I can put on the CLSC. So there's also that perspective when I try to manage my beds, because I know that I always say in the emerge, sometimes I have a little window that's open, and I want to try to discharge that patient in this window, because even if I bring them up, I know that this window is closed, and it becomes even more complicated to try to discharge that patient. I think somebody is bringing up in the, do you want to say, Andrew?
Sure. Well, I think Monica was just bringing up the possibility of having some sort of discharge sheets for people that would have, I guess, links and information about the resources that you brought up, Julia. I think that could be helpful in terms of possibly discharging these people for the short term while waiting for a lot of these support mechanisms to kick in.
Yeah, I think it's a great idea. I never thought about that. It could almost be a nice QI project. Yeah, so all of that to say about this caregiver burnout, that for us also, it gives us a little bit of leeway to try to discharge sometimes from the emerge. But I really understand that if this is a consult that comes in at 4 o'clock, it's a whole different story. I don't know if there were any other comments before we move to the third case.
I might have just a quick question. In terms of waiting lists for CLSC and geriatrics outpatient, what can we expect? Because if my patient can be seen in a week versus in 3 months, well, it changes things.
So unfortunately, I don't have a clear answer to that for multiple reasons. The first one is that every CLSC is different. It's very heterogeneous. And even sometimes when I discharge patients and I say, where do they live? And if I know that, for example, they live in Verdun has a fantastic CLSC, I know that the prise en charge is going to be much faster than if they are in other areas of the town. However, in complex cases like that, often what we'll say as a team is we'll say we want to have the date and the time when the CLSC will actually enter the house, because otherwise it's not safe for a discharge. But those are a little bit more complex to organize. If you just send from the emerge, if we just send a dizzy, sometimes before the home evaluation gets done, it could be 2 to 3 months just for the home evaluation, unfortunately. I think Dr. Bake has a comment.
Yeah, Mark, did you put your hand up again?
I just have a question. When it comes to CLSC referrals, are they prioritized differently if they're evaluated by a geriatric team than if they just get a referral from a GP or an emergency doc?
That's a good question. I think often the more details they have, and if they have a precise diagnosis, it helps them to better triage them. However, I don't think because it's coming from a Geri team that they will be better prioritized. I think maybe just the way that the dizzy is filled could make a difference, however. Okay, so we're going to move to the last case that we have to close this up, and it's again another bread and butter. So confused patient in the emerge. So 92-year-old frail lady comes in by ambulance, and it's the middle of the night. Then a neighbor basically said she's been confused for a few days. He called the ambulance. We don't know anything. We don't know her past medical history. We don't know which medication she's on. When Urgence Santé came in, they think that she was living alone. They noted the apartment was dirty. The patient is disheveled. She's a bit tachycardic. She's coughing. Her chest x-ray shows an infiltrate in the right lower lobe. And she's agitated overnight. She falls off of her stretcher and she gets put under restraints in the emerge. So I'll let Andrew present his thoughts.
So we'll get through it quickly just to leave time for discussion. So obviously there's a bunch of things going on with this lady. It sounds like a case of delirium brought on by a medical illness. So first of all, good on whoever heard the auscultatory findings in the busy emerge of this lady who's yelling and screaming. So good job to hear those crackles and get the x-ray. And so there's a pneumonia there, we'll treat it. That's the easy part, with supportive care, whether Tylenol and IV fluids as needed. But I'm not going to stop there as far as searching for the etiology of the delirium. There's a lot of stuff here, whether it's the living alone, being confused, the dirty apartment, a lot of things here suggesting maybe dementia, but probably delirium now. So in the 92-year-old or whatever she is lady, we're going to get a CT head, again, do a fairly extensive lab panel, urine cultures. We're going to try to look through all of her medications to see if there's stuff that might be contributing. We need to basically get more information that this patient can't provide us right now. And while that's happening, obviously, like I said, we're going to treat the pneumonia. And in order to do all that properly, we're going to have to treat her agitation. And obviously, that's a big thing. She's already fallen here. I would like to get to her with treating the agitation before the fall, ideally, but we're going to treat it nonetheless. I'll talk a bit more about that after, but I would give Haldol 1 to 2 milligrams. And I'd like to get her get all the requests in, the treatment started, and essentially just put in the medicine consult, because to me, this is a delirious, tachycardic 92-year-old with pneumonia, regardless of whether she needs IV or PO antibiotics, or does she need oxygen or not. To me, this should be admitted to medicine, and any sort of more Jerry issues in the background can be dealt with a little bit later. That would be my approach. And the next slide, I think we'll talk a bit about the agitation. So obviously this is a big thing for the elderly in Emerge. We want to make sure that we treat it early to prevent these kind of falls, prevent them being put in restraints as much as possible. But we do have to be aware that 2 or 3 days down the road, we could be dealing with worsening delirium or other issues if we're giving doses that are too high. So we want to start low and go slow-ish. I say slow-ish because we do have things that we need to get done. This is in the middle of the night. We don't want the CT not to be done for the day team because the patient went up 2 or 3 times and was too agitated to sit still for the CT scan. So we do have to get them sedated appropriately to be safe. But in order to get the workup that needs to be done, we have to protect our already overworked and frazzled nurses and other treating partners to make sure that they're not being abused. But we would, for the patient's sake, like to get the restraints off as soon as possible as well. And that's one thing that I try to do with restraints orders whenever they're needed is to write actually something in the orders, like a time frame for them to be reassessed when they can be taken off, because I think it's not good to just sort of leave them on because the nurses have a hard time getting back. I think there should be a set endpoint on the restraints unless you need to reassess the medications. But we'll let Julia think a bit more about that.
Thank you. So one of the things that I really want to do with this case is, first of all, I want to clarify, is this really a delirium or a progression of dementia? So it's not rare that I'm getting consulted for a delirium, clearly, I mean, this patient has a pneumonia, there's something going on. But maybe this is just her dementia, and maybe she's actually not delirious. And maybe she actually would be able to be discharged from the Emerge. We never know. It all depends on the story. So the first thing I just wanted to say is, who's at risk of delirium? I mean, it's a very simple graph over here, but we know that if you have somebody who's very, very frail, has tons of comorbidities, already has cognitive impairment, they're at much higher risk than becoming delirious than if any of us had the same insult, basically. So it depends on the vulnerability and the precipitating event, basically. So my big question here would be if, and hopefully the neighbor or somebody would be able to give me a bit of info, but do you find that this patient is more confused than their baseline? Because what bugs me in this whole story over here is that the apartment was found to be dirty, she's disheveled. Like, is this, if somebody becomes delirious to all of a sudden, is that enough to make their apartment dirty, like within 24 or 48 hours? Or maybe this is actually something chronic that nobody actually noticed, because sometimes the signs can be very subtle. How can we assess the patient for delirium? You've all heard of the confusion assessment method. I'm sure. I mean, it's four criteria: acute fluctuating course, inattention, disorganized thinking, altered level of consciousness. The reason why I want to bring that up is there's a few little things you can do at the bedside if you want to kind of check for delirium. I like the CAM ICU here, which I'm sure you've seen done in the ICU. But basically, they do little tests to check for attention and also to check for disorganized thinking. So they basically ask the patient to squeeze the hand when they hear the letter A. So they say save a heart. Disorganized thinking. So will a stone float on water? Will a stone float on water, for example? So very simple little question. So at the bedside, if you guys are thinking about delirium, anything that tests your attention is usually a good test. So serial 7, spelling the word world backward is also a good one. Again, serial 7, digit span also could be a good one. The ones that I think are the easiest to use at the bedside and that I use all the time are asking the patients to tell me the months of the year backwards. And then when I say that, everybody says, oh, it's so complicated. It's actually not complicated to do. We can all do it. But asking the patients to tell me the months of the year backward. Of course, if somebody has an advanced dementia, they may not be able to do it. But if somebody is mild or even moderate dementia, they usually would be able to tell you the months of the year backwards, or at least the days of the week backwards. So something, a very, very easy tool at the bedside to use. If this is a delirium, if really the story that I'm getting, of course, I'll have to complete investigations. However, if this is a progression of dementia and it is a patient who presents with a pneumonia, maybe I'll be able to discharge her home because she doesn't need oxygen, because maybe she's not so sick. If maybe she's already known to the CLSC, maybe there is something else, but I need to get that story to be able to. I mean, you guys know all of those investigations for patients with delirium. The last thing I wanted to say is my biggest fear with those patients is actually the iatrogenic complication of agitation. So Andrew mentioned avoiding restraints, which I'm very happy to hear somebody from the eMERGE say that. But sometimes, I mean, we always say we favor a non-pharmacological approach. I am realistic. However, I completely understand how difficult that is to have in the emergency room. It's everything to make everybody agitated. But often if there's a family member, if you're not in a COVID times, but if there's a family member that can be at the bedside that can reassure patient, that could be better than any Haldol we give. Having a calm behavior, so just the attitude that we have with patients also can help. If we need to have a pharmacological approach, we always say last intense, but at the same time, it's true. If you're in the emergency, you need to get the CT head, you need to get your workup, you need to get your chest x-ray, this. So I like what Andrew said when he said lowish doses. I like to say start low, go slow, but you have to go somewhere also at the same time. I would, however, be a bit careful with the 1 to 2 milligrams of Haldol. Often what I would recommend is start with 0.5 of Haldol. And if it's not enough, then you can always give another 0.5. But often we don't really like to go more than 1.5 milligram of Haldol in the eMERGE. It is true that sometimes you need to give higher doses. However, I would say start with 0.5 and then reassess it. If the patient is not able to take if the patient is collaborative enough to take something PO, the atypical antipsychotic that's probably the most effective is risperidone. That would probably be the Geri dose I would start on. Just so that you know, there's much less evidence for quetiapine, especially for agitation. So because the doses that we give of quetiapine to the geriatric patient, at 25 milligram of quetiapine, it's probably not going to really touch that patient. If you're lucky, it's going to put them to sleep a little bit. But the risperidone is much more antipsychotic effects in a sense. I would really try to avoid benzodiazepine as much as possible, because it's really not rare that then just a few hours later they will get delirious. So I would really, again, it's not what we like to do, but I would probably go for a low dose antipsychotic instead of a benzodiazepine. I don't know if my computer, and these are just for reference, but these are some of the other atypical antipsychotics that sometimes are used, and the maximum dosage or typical doses that sometimes we can use. So I think we're past 2 minutes. I'm really sorry. I don't know if we have time for 1 or 2 questions before we wrap things up.
I think we could take a few questions, maybe 1 or 2.
Can I ask one quickly?
Julia, you can ask a question on your own presentation. Yes.
I'm curious what Julia thinks about maybe more short-acting medications for, like, specifically getting a CT done, like a dose of ketamine, Versed, these kind of things. Have you guys in geriatrics looked at that, and do you have preferences?
I would Versed I would try to avoid, because it is still a benzo, and it still makes us run into trouble sometimes. I mean, I don't have a lot of experience with ketamine because we don't give it on the floor, to be honest. But I have seen that there is some, because it's so short acting and everything else, that maybe it is a good solution. So you guys are probably much more experienced than I am with this, though.
Well, I want to thank you both for being here today. It was a great presentation, outline very bread and butter presentation that represent a real challenge every day. So thank you so much. I hope we can see you at rounds again.
Thank you very much. And if you guys have any questions, these are our emails.
Thank you so much. I will let Lars introduce our next guest speaker. We're really excited. And I want to take this window to thank him for all the work he's done this year and the help he's provided us with rounds. We really appreciate it. Thank you.
Okay, sure. Can you hear me? Yeah, okay, perfect. So it is my great pleasure this morning to introduce to you a towering figure in emergency medicine research. It's Dr. Ian Stiell. He needs no introduction. I'm sure we all know who he is, but even if you did not know who he is, if you practice emergency medicine, you would know who he is because you would use his work every day. I'm talking about things like the Ottawa ankle rule, the Ottawa knee rule, the Canadian CT head rule, the Canadian CT C-spine rule, and other things. So we're all very familiar with his work, and his work speaks for itself. And even better than this, or beyond this, he's actually a graduate of the McGill Emergency Medicine Residency Training Program. Since leaving our hospitals, he has gone on to become a distinguished professor of emergency medicine and epidemiology and public health at the University of Ottawa, a senior scientist in the Ottawa Hospital Research Institute. He's also was the first chief of the emergency medicine department at the University of Ottawa. He has more than 400 peer-reviewed publications, of which over half of them, or roughly half, he's actually first author or the senior author on the papers. He's held more than $26 million in peer-reviewed funding as a PI. He has set up and directs the Ottawa Hospital Institute Emergency Medicine Research Group, which I think it's safe to say is a standard not only across Canada, but internationally as well for emergency medicine research. So you can see that he's a towering figure in this field. He's literally written a book on many subjects in emergency medicine. His research focuses mainly on two things. Those are clinical decision rules, which we're very familiar with, and also acute cardiac conditions. We're talking about things like cardiac arrest, and in atrial fibrillation in particular, I think it's safe to say that he's redefined the standard of care for this condition in the emergency department. And we're so lucky to have him talking to us about that today. Thanks so much for joining us. You can imagine that Professor Stiell has an extremely busy schedule with a lot on his plate. So we really appreciate the time you've taken to talk to us today.
Thank you, Lars. Can you hear me okay?
Absolutely, we can.
Okay. Hopefully the lighting doesn't show how much I am blushing from that over-the-top introduction, but thank you very much, Lars. If I've done a lot, it's because I've been doing it a really long time ago, and I graduated from your program many decades ago. I won't exactly tell you when, but as you know, McGill was one of the first 3 emergency medicine training programs in probably the whole world. So I'm proud to be an alumnus. Thank you so much for inviting me. I'm going to practice sharing my screen here to see if it actually works or not. So are you seeing some semblance of a slide there? Yep, okay. If I go slideshow, what happens? Okay, so I can't see anybody when I'm full slideshow. And so it helps me to watch and see, if Lars is falling asleep or, and Sophie is falling asleep or she's looking at her her Twitter feed, which is okay. I do that too. Anyway, we're probably wasting a lot of time here. So I am here probably in the worst week of this year. Both Ontario and Quebec set new records yesterday for hospitalizations. It was minus 26 degrees without the wind chill. Emergency folks are really resilient, and we had a huge meeting in our group yesterday, and it's amazing how everybody is banding together to get through this mess, this super mess. So I applaud you all for what you're going through in your EDs. So let me move along here and see if I can There, okay. So I'm going to talk about atrial fibrillation, which is one of my favorite topics these days. I have a couple little disclosures that I don't think should impact anything that I'm saying today. I don't receive any money personally. It's all unrestricted contributions to our research. So I'm just going to remind you what we mean by acute onset AF. We'll look at a case. What's new in the evidence? What are some of the other guidelines besides those of CAPE? And then we're going to dive deep into the CAPE guidelines because there's a lot of stuff that's new and some of it's controversial. And what I really want are people to ask me questions. And I may not be able to follow the chat or whatever, but Lars, if somebody has a burning question as we go along, I'm more than happy to take a second and take it right away instead of waiting to the end. Okay, so when we talk about acute onset AF or atrial flutter, these are symptomatic episodes where cardioversion is still an option because the onset is generally less than 48 hours. It could be a week if their patient's fully anticoagulated. It could be the first time or it could be recurrent, also known as paroxysmal. It definitely excludes patients with permanent or chronic AF. As we all know, these patients show up in the ED. They got nowhere else to go. It happens on the weekends, in the evening. They can't go see their cardiologist. They have to go see us. And as you probably know, that generally speaking across the country, we prefer immediate cardioversion with shock or drugs and sending the patient home. But interestingly, that is far from the standard in most countries elsewhere. So we're kind of a leader, I think, I like to think, in Canada. So let's start with this case here. We have a 67-year-old gentleman with sudden onset of palpitation 6 hours ago. He feels a little weak, but has no chest pain or shortness of breath. He's never had this before. Takes a statin and perindopril for hypertension, not anticoagulated. His vitals show a pretty rapid heart rate of 8 fib. So just tell yourself what you think the answer is. Is it safe to cardiovert in ED or is it not safe? According to current guidelines from the Canadian Cardiovascular Society and CAPE. Okay, so make a note to yourself. Answers will be revealed imminently. Okay, same case, but the guy stays at home. He's not married, so nobody was bugging him to go to a hospital. So he shows up after 24 hours. Everything else exactly the same. So is it safe to cardiovert this guy with drugs or shock in the emergency department? Yes or no? Okay. So there's only one right answer to each question. So this one is a definite yes. He's coming in under the magic 12 hours. Doesn't matter about his comorbidity. You can safely cardiovert this guy. And this one, according to the latest guidelines, is a definite no. Okay, because if you look, I weaved in there two of the Chad's 65 criteria. He's over 65 and he has hypertension. So he has two criteria, and that makes him only safe if he shows up under 12 hours. So 12 to 48 hours with 2 or more Chad's 65 criteria is a no-go for acute cardioversion. Okay, so that's an important point that we'll come back to a little bit better. I don't know if I'm preaching to the choir here, but rhythm control, in our opinion, is way better than rate control for these patients. The patient gets to go home quickly and sinus rhythm, back to normal activities. You don't have to prescribe rate control agents on discharge. They may not need oral anticoagulants depending on their CHAD 65 status. Better for the hospital. Our hospitals are a mess these days. I'm sure your ED is just like ours. Like, you can hardly find a monitor anywhere. So they're leave the ED and they can get off the monitor almost always in less than 6 hours, and it avoids unnecessary admissions where our hospitals are packed. A couple of recent studies. This is our RAF2 trial. It was in Lancet 2 years ago, where we compared a drug shock to shock only strategy, and it found they were both highly effective and rapid and safe, and that overall, regardless of whether you started with procainamide or you started with a shock, 96% of patients went home in sinus rhythm. We found that the procainamide infusion worked for 50% of people, and therefore avoided the what we call resource-intensive procedural sedation. And we'd say that immediate rhythm control therefore leads to excellent outcomes. And this caused some controversy in other countries because they just don't get it. Much more recently published paper, it's a RAF3 trial that was conducted in 11 hospitals in 5 provinces. The MUHC with Greg Clark and Dr. Nemeth were the local site champions for this study, which was conducted about 2 years ago, over a year. So many of you were hopefully aware of the study, where we implemented the CAPE HOFib checklist into these hospitals. 5 different provinces, and overall the results showed definite decrease in length of stay in the emergency department, increased use of cardioversion by drug or electricity, and no increase in adverse events whatsoever. And hopefully my wife will pick up this phone call. Thank you. Okay, so much for that. As you can gather, I'm at my home office here. Early cardioversion therefore allows AF and AFib patients to quickly resume normal activities, was the conclusion. We're just for those that like to count, we're also in the midst of RAF4 trial, which is comparing procainamide to vernaculant for acute AF, and we already recently got funding for RAF5. So this RAF thing, this graph gig is going on for a while yet for me, keep me amused. Some guidelines. The Canadian Cardiovascular Society puts out new guidelines every couple of years. They did a major overhaul 2 years ago. We have the American Heart ACC guidelines, and we have the European Society of Cardiology guidelines. And I keep a close eye on all of them. And they're the same in one regard, is that they don't really know what emergency departments are, or they don't really care what we do, as long as we do what they tell us to do. And even the Canadian guidelines only had one emerge doc, Claire Atzema, who felt greatly outnumbered by the 20 or so cardiologists on the panel, and found that often the cardiologists were making decisions about what we should do without really considering the implications for practice. We'll come back to that in a minute, but there's a couple of points in their guidelines that we disagree with strongly. The CAPE group just published last September our second version of the best practices checklist. This was originally created in 2018, and as a panel of 20 doctors, including a number of academic cardiologists, along with academic and community emerge docs, a couple of patients. So we had a wide input into these guidelines, which were adapted from the Canadian Cardiovascular Society. So we didn't start from scratch. We took their, and we discussed them at huge length and adapted them for purpose of emergency medicine practice in Canada. So we're trying to help those that don't have time or the inclination to read the Canadian Cardiovascular Society guidelines. We have done that work for you. And we like to think that these are rock solid for advice. It's an open access publication in CGEM at this link if you haven't got it before, and we can make that available to you again, but it is open access on CGEM through our publisher Springer Nature. So, so let's move on then to the guidelines in detail, talking about rational management. Some of these constructs. Should you cardiovert? Is it safe? What about rate control, ideal rhythm control? How do you prevent strokes? And then what do you do with the patient when you've finished treating them? So we have this diagram which shows 4 main components. So this, don't like worry about the weeds here. This is just to show you there's 4 components. A, assessment, risk stratification. Is my little mouse thingy visible to you guys, or when I'm sort of moving around?
Yeah, we can see it. Yep, we can see it.
Yeah, okay. Okay, rate or rhythm control, how do you do that properly? What do you do? What are the considerations to be sure your patient doesn't stroke? And then admission to hospital, discharge, and follow-up stuff. So we'll go through all that. And again, I'm happy, you know, if I'm saying something that you think is a little bit ridiculous, just you can even shout out or put something in the chat that, and Lars will let me know, I hope. Okay, so first off is assessment risk stratification. Some of the big questions are, is this a primary arrhythmia or secondary tachycardia? Is the patient unstable? Have they been anticoagulated? And are they safe for acute rhythm control? So this is something that we all need to know, because these patients show up every day. So is this a primary arrhythmia where they suddenly gone into paroxysmal atrial fib, or do they have permanent AFib and their heart rate has gone up because there's something medical going on, like sepsis, bleeding, PE, heart failure, ACS, etc.? Because the treatment for the 2 situations are completely different. All right, for if it's a secondary tachycardia, then you treat the underlying cause, okay, aggressively. Cardioversion can cause grief or significant morbidity, and rate control may also do the same. So avoid them and treat the underlying cause. Now, on the other hand, primary arrhythmia, you got to treat the arrhythmia, and we'll get into that in a little more detail. How do you tell the difference? Because they don't come with a label all the time. So the consensus of our group and the cardiologists is that it's more likely to be medical if the patient wasn't aware of sudden onset. They don't have palpitations. You already know they have AF. They're on anticoagulants. Old ECGs show that. They never have been cardioverted in the ED ever. Heart rate is usually quite a bit less than 150. And they obviously will have fever, dyspnea, pain, other stuff, clues. Okay. So next thing, and those of you that have, well, everybody's done ACLS, but ACLS guidelines are pretty not great on AF, because they just want you to shock everybody, is the way I read it. And if it's a primary arrhythmia, sudden onset of paroxysmal atrial fib is really uncommon to be unstable, unless they're in a rapid ventricular pre-excitation, very uncommon. And what do we call unstable? Well, we're talking about significant hypotension, ongoing cardiac ischemia, or pulmonary edema. So these are the few situations, and sometimes patients having an MI, and you can't tell whether the rapid heart rate precipitated or what. At any rate, those are the few cases where urgent electrical cardioversion is indicated. Okay, but you know, it's I know the younger doctors, trainees love to cardiovert, but there's times where you staff guys have to just grab the paddles out of their hands and ask them to step back, don't shock. Okay, so let's get into the details of rate or rhythm control, and we'll talk about ideal rate control when that's indicated. We'll talk about options for rhythm control, and we'll spend a minute on WPW, which is something that we all must know about. So this is one of the most important slides. I'll just sort of work through it slowly. So if a patient has acute onset AF and they're chronically anticoagulated, then it's okay to cardiovert them. However, lots of these folks are not anticoagulated, unfortunately, and you can cardiovert if they've never had a stroke, they don't have valvular heart disease, and it's one of the three. So this is where our case example comes to light. So if they show up in 12 hours, good to go. If they show up after that, less than 48, it's only safe if they have less than 2 of the CHAD 65 criteria, the comorbidities that increase the likelihood of stroke, or you're lucky and you can get a transesophageal echocardiography, which is usually only available in large hospitals during the day time. So we have tried to simplify the CCS advisory because they're quite complicated, and we argued about this for 2 months to come up with this wording, and we stand by it, but it may in itself be a bit confusing and need interpretation. So I don't know if folks have a question for me about it to try to make sense, or Lars is frowning big time, so
There doesn't seem to be any question in the chart. I think you're being so clear.
Oh, okay, cool.
Chat, people are sharing the resources that that you're mentioning.
Okay, yeah, I see a few things on the chat, but yeah, okay, that's fine.
And here, I think, well, my main thing is that happens to me a lot is that I meet the patient and they tell me, it was 3 hours ago, I think. Yeah. I think it was 3 hours ago. And then they're trying to remember whether they had any palpitations before, and they kind of don't really seem that sure, they can't really tell me that, oh, bang, it started at this time. I don't know how you generally handle that.
Well, I've been doing this for a while, and I actually honestly find that's not the case, except for the old folks who come in feeling weak and they don't have palpitations. It's only the triage nurse who discovers how fast their heart rate is. But most people, they're especially if they've had it before, they suddenly recognize their heart's going too fast, and they watching TV or whatever, going for a walk, or they were fine when they went to bed and they got it in the morning. So I don't find personally it's that hard to determine that, especially within the windows we're talking about, within 12 hours or 48 hours, which are the key ones. But it takes some practice, and I know that bothers a lot of people, so it is a concern for doctors. But generally, I think quite a few folks, doctors, have a fair degree of confidence in making that. I don't know if that makes it worse or helps, Lars. Oops. Okay. Well. Okay, I'm going to move on. So there are patients where, as we've just discussed, it's not safe to cardiovert. So then you're going to go for rate control. And I must say, I learned a lot from the cardiologists on our panel, and I like to think I know my stuff. But with regards to proper rate control, I wasn't doing it as well as I should have been. Okay, so I learned a lot. So we recommend for most patients, calcium channel or beta blockers. Typically our first line. If you're having trouble, try the other one. IV DIG is a very good second line option, and rarely you have to call in cardiology, but we find we don't need cardiology very often with this stuff. So calcium channel blockers, you avoid if the patient has overt heart failure. So the big mistake that many of us make is that we're not aggressive enough in repeating the dose. So I used to hang a little baggie of diltiazem, come back in an hour, and then repeat it. So according to the experts, you should repeat it every 20 minutes so that they get up to 3 doses in the first hour to get the heart rate down. Ditto for beta blockers. Metoprolol is usually the go-to, and you can repeat it 3 times in the first hour to get the heart rate down. Dig is still around. And when I was back at the Royal Vic during my residency, that's about all we had was Dig. You know, they hadn't even invented verapamil, if you can believe it. I mean, you probably couldn't believe it, but yeah. Okay, so Dig is the go-to drug. The main drag on it's slow. It takes, you know, you have to space the doses out by 4 to 6 hours. And it's something to consider if the patient's blood pressure is a bit soft or they're in acute heart failure. And it's not really safe to shock them. You know, so it's a good drug. Don't be afraid of it. And you want to get the heart rate down to 100. If you're going to send the guy home, and preferably get him up for a little walk and ensure it doesn't go sky high again as soon as they move around. So try to get the heart rate down below 100 is recommended when you send them home. Our checklist gives you recommendations on oral dosing for discharge. And one of the things I forgot to put on this slide actually is that after the first hour, you should probably give them the first oral dose of beta blocker or calcium channel blocker to kind of prevent the rebound effect. And our guidelines, the checklist will give you exact dosing. So in theory, that's the only reference you will need most of the time.
Yeah, we do have
yeah, shoot.
The question from Pavel in the chat is, what about using calcium channel blockers and beta blockers in the same patient? Do you have to be more careful? Do you have to reduce dosing, or is that, or just go ahead the same?
Well, yeah, so the cardiologists tell us, say you've given Dizondilt at home and you give them 3 doses and nothing happens, that it is okay to go to metoprolol if there's no contraindication, such as, you know, heart failure or low blood pressure, or you go to Dig. Depends how much rush you are. Yeah,
so basically just try whatever, and if it doesn't work, then move to the other agent. And
yeah, that's the recommendation. Yeah. And if you were, you probably have, I don't know, like 30 cardiologists at your hospital. And if you ask 30 of them, they would all disagree. So
I've
that's
noticed
why don't consult them. Like, just do it. You don't need those guys. Okay. So I think our RAF2 trial showed that you could start with procainamide or you can start with shock. You get pretty much the same result. And a lot of it has to do with the patient and physician preference, okay? And I think it's important here to have a chat with the patient. I know a lot of doctors in certain provinces really like shocking for apparent economic benefits to their group, which sort of saddens me. I think patients should have a say, you know. So my personal preference is to try the procainamide first because it works half the time. However, the patient might tell you, well, they've tried that 3 times, it never works. Just shock me for Pete's sake, kind of thing. Are you having a little puff of oxygen there, Lars? He's fit testing.
Sorry, I'm actually in the emergency department and a colleague just came in, so I had to mask.
Yeah, no, that's fine. That's okay. You can't be too careful these days, man. Yeah, I got my N95 ready to go, and I'm at home. So, okay, so we have shown in the past, if you're going to cardiovert, don't waste time with rate control agents. It just waste time. It does not make shock or cardioversion more effective. Okay, procainamide, pretty standard, 50 milligrams per kilogram in half a liter of saline over 60 minutes. Now, this is a much more slower infusion than we did in RAF2 because we found a fair number of patients became hypotensive. So 2 ways to prevent that is to put it in 500 of saline, and second, give it over 60 minutes rather than 30 minutes. If the patient's pressure is under 100, then don't give it, or try a couple of mini boluses of saline to try and get their pressure up a tad. Okay. Now, this red one, amiodarone IV not recommended, caused a lot of consternation, especially for your residents who have just come off ICU or what have you, because amiodarone is used all the time in ICU and CCU. And our argument is that those are different patients. They're already super sick with sepsis or an MI. Our patients aren't super sick. They have a pure arrhythmia, and amiodarone is not very effective. Doesn't work very well. And it's really slow for our patients who have primary arrhythmia. So we strongly, the group strongly discourages amiodarone. Other options that are sometimes available. So in Canada, we have IV vernaculant, but it's not available in most hospitals because of price. We have IV butylide, which we tend to avoid because of the problem with torsade de pointe. And we do not have IV propafenone or flecainide available in Europe, but not in North America. And we find giving the oral version of those agents is too slow because we're all wanting to move along. Okay, electrical, that should be, oh, go for it. Did I get somebody upset about amiodarone?
No, not at all. So there's Will Grad comments about calcium channel blocker dosing, saying that in elderly patients, he has found that a lower dose is often very effective, 0.25 milligrams per kilogram of cardizem in older patients, because he found sometimes there's a drop in BP. And then I guess this is a question slash.
Is he saying the dose that I'm showing right there, 0.25?
Oh, maybe he's saying lower. Maybe Will wants to comment himself. I'm not sure.
Yeah, I'm saying that standard dose of 0.25 milligrams per kilogram is sometimes a bit too much in elderly people. From my experience, I tend to err on a lower first dose, sort of as a test dose with them, because they might overreact on the BP or the heart rate side. That's been my experience. I'm just wondering if you feel any different.
That didn't come up in our discussions. Certainly you give it over 10 minutes, like, that's why we put it in a baggie. So you don't have the temptation to just push it. So generally speaking, we have not seen that problem, but I don't see an issue with it. I think you always want to be cautious, and I don't know what you're determining as elderly, but as I get older, elderly to me means like, I don't know, 85, 90. And our studies have included lots of folks up to the age of 100. Anyway, wow. There's different ways to do it.
Okay,
for sure.
Another comment slash question, I think, was what about magnesium? Joe Nemeth put in the chat, magnesium, a free shot worth a try as well. It might help with the patient's migraines. Have you?
Yeah. Okay. Yeah, and all the other things it might have are asthma. So we do not recommend routine use of magnesium by itself. Now, if you are in love with ibutylide, then it's recommended, a real pre-treatment. But we don't recommend magnesium. So.
Because you feel it's ineffective, or you found it's ineffective, or
yeah, there's no, I haven't seen good evidence for it, and all the guidelines I've read from Canada, US, and Europe, they don't talk too much about it. Yeah, so that's so. I guess no harm in trying it, but I don't think it's going to generally get you too far, and. I'm happy to duke it out with Joe later if okay.
All right.
I welcome these kind of comments because they're of interest to me, and so keep them coming.
Okay, well, we got one more. I think it's starting to heat up in the chat here, which is
good. They're not shy after all.
So the apparently some members have had cardiology complaining about our use of diltiazem, sometimes saying that it has caused new onset heart failure and somebody with a previously normal ejection fraction. Is that a well-founded complaint or concern by our cardiology colleague, or does that not really make any sense based on the evidence that you?
Well, you know, they're not in our shoes. They don't have this patient. You know, they're sitting in their office leafing casually through all their past records. So if you happen to have an echocardiogram that shows a very poor ejection fraction, then yeah, that's a reasonable comment. Ours says acute avoided heart failure, right. And there's different ways to define that. Obviously, if they've got, you know, heart failure on POCUS or X-ray, then avoided. But if they don't, and you give it like this, I don't think it's a problem, you know. But that's why you don't want to talk to those guys.
Okay, all right.
It's a fair question, though. If you know the patient has a lousy ejection fraction, yeah, don't use this stuff.
Okay, so the point, avoid in a patient with heart failure.
Yeah, or really low ejection fraction.
We also have a comment about the East. I'm going to take a couple more maybe here because they're all related to the different medications.
Yeah, sure.
And then maybe we'll let you move ahead because I don't want to stop you from completing either. But so there's an East AFNet 4 trial that I'm not very familiar with. I don't know. Are you familiar with that? Because I think otherwise.
Not by the name, but I know the author, and I don't know if it's published or not published. I know all the published papers, so I don't know if somebody can explain to me which study it was.
Yeah, maybe Kavi can explain because I'm not sure I exactly understand Kavi Singh's comment, but I don't exactly understand the.
Hi guys, are you able to hear me?
Yep.
It was basically a rhythm versus rate control study, and it showed fairly similar. They were looking at the primary composite endpoint of stroke, death, and serious adverse effect. So I think overall it showed that there was a small advantage to rhythm control in terms of overall mortality. Slightly higher rate of adverse events with rhythm control. And just back to the question Ian had mentioned earlier, that in terms of immediate hospital resource utilization, rhythm control has some advantages. It's faster, they get out within 6 hours. But the one thing I'm not sure about is in terms of if you rate control somebody and they stay on the medication, do they have less recurrence? Do they end up over the course of a year or 2 or 3, if we measured it that long, actually coming back less and using less resources? And I don't know if there's any.
No, that's a good question. First off, I'll have to read up on this study again. And I don't know if it was done in the emergency department or in cardiology clinics, which is often the case. I know the famous AFFIRM trial, most of those were not acute patients. They had been in AFib for some months. And I've talked this over with the first author from Calgary, George Weiss. So there is no good emergency department study comparing rhythm to rate control. And I've wanted to do one for 20 years, but it's not feasible in this country because most of the docs are doing rhythm control. So I would argue there's no good evidence that rate control is better for patients. If we rate control them in the ED because they came in after 12 hours, they still have to come back in a month, and typically we'll have a trial of cardioversion anyway. That's the standard procedure. So they're just likely to get cardioversion a month later. But it's a good question. Right? I mean, very good question. Where are we? Okay, I'm just going to move along here quick. I don't know how tight you are. You're gonna like.
Please go ahead. Maybe we'll save there's one other question, but we can save it for.
Yeah. Well, okay. Well, I don't know. You guys gonna open the trap door at 9:35 and go in. Anyway, okay. I think I can get through this in 5 minutes, and then I want to bring on the questions. Okay. So electrical cardioversion. easy to do in a large hospital, not so easy if you're the single doctor in a smaller hospital, but you all know how to do procedural sedation. And I would argue that this is easier than managing a dislocated shoulder, is my personal opinion. And Emerge Doc should own this. Paddle position, we did that in our Lancet trial, and it's found that anterolateral or anteroposterior were equally effective. So it's easier to start with anterolateral, but if it doesn't work, then go to anterior posterior. Try a different one, okay? Make sure you start with adequate energy, which is 150 to 200. Like the old days, it was start low. That's not the case. Start high, shock them once. If you're having trouble after a couple of shocks, which is very frustrating, as I say, try a different pad position and then apply pressure to the pads. And maybe take the old-fashioned paddles out and press on the pads so that there's better contact. And in our hospital, like we use propofol, they're awake in 15 minutes and raring to go. We don't keep them around more than 30 minutes after a cardioversion, either with procainamide or with shock. WPW is an important condition, not common, but it's life-threatening. Obviously, if they're unstable, shock them. And when you see that ECG, you just want to shock. But some are more stable and talking to you. So you can try either procainamide or ibutyl. It's quite safe. The whole bunch of drugs you must never use, and you will fail your Royal College exam on the spot if you suggest to give any of these drugs to a patient with rapid ventricular pre-excitation. So I think you all hopefully know that. Oh geez. Okay, so my wife and I were supposed to go to Florida to play golf and tennis in November, and that got canned for obvious reasons. So we went a little holiday in Canada, and I'm gonna do this quiz here, geography quiz, and ask you who knows where these four pictures were taken. And Lars has a nice prize for the person that got. Okay. There might not be a prize other than the glory of knowing where things are in your own country. So where did we go for our vacation?
Oh, we already have votes here.
Oh yeah, okay. Any of them right?
So we have 2 votes for British Columbia, one specifically for Desolation Sound, one for Vancouver.
Okay.
Miriam says Vancouver. Anybody else got a guess? Antoine Perron, Squamish, Joel Turner, Nanaimo.
Okay, these are some good guess. Yeah. Okay.
Tofino, Willgrad.
Yeah, we're on Vancouver Island. This is Parksville on the East Coast. This is Acute on the West Coast of Vancouver Island with these sea lions. They're very noisy rascals. My wife, Acute, people go there in November just to watch the storms come in. It's crazy. And this is Tofino, which is awfully beautiful, and you can take a boat out. So, okay, now, all right, I better get back to work here, okay? No more goofing off. Stroke prevention. We have to talk about long-term OAC and how to do it. Short-term, for those that are cleared by TEE. So who do you anticoagulate? So generally speaking, we're prescribing OAC for long-term stroke prevention. And hopefully most of you are familiar with the CHADS criteria. And it should have said, this slide was for a European presentation. It should say CHADS 65 there, which you're all, if CHADS 65 positive, stroke, age 65, diabetes, hypertension, heart failure, if they have any of those, they're supposed to be on OAC for the rest of their life. Okay. Now, you got to talk to the patient. You can't just dump it on them, but you need to explain it to them. If they have coronary disease, it's a little more complicated, especially if they have recent intervention. You might have to talk to cardiology. If they're negative, CCS wants you to start 4 weeks of OAC for everybody. And we don't agree with that. The Cape folks say that's a bit much. You know, you got a young person who had one episode of AF after, big party celebrating their Royal College exam success, and the next day they go into AFib. And do they want to take OAC for 4 weeks? So this is a shared decision-making process, and it's based, as we point out to our CCS colleagues, this is based on very low quality evidence, and it's a weak recommendation, which means you can do it or you don't do it. So don't feel bad if you don't do it, because my colleagues have got a lot of pushback. Okay, another little pearl is if they come in, you document they're in AFib, and then they convert before you can do anything, they still have to be considered for OAC. You can't ignore that one. Kirsten DeWitt and her colleagues at MAC, while she was at MAC, came up with this nice checklist of who is not safe to receive anticoagulation. That's in the checklist because it's too much to remember. Which anticoagulant nowadays, DOACs are definitely preferred. Warfarin is preferred if you have mechanical heart valve, moderate to severe mitral stenosis or renal failure. And we recommend that you just get to know one DOAC. You know, they all have positives and negatives. The Thrombosis Canada app is really, really good for details. And those are some of the details. But this is all in the checklist, so don't scribble it down. One point that's come up loud and clear is if the patient is in renal failure, don't start them on anything without talking to their nephrologist. All right. You have a dialysis patient who has an episode of AFib. Don't start them. You do not start them on DOACs for sure, and you may not start them on warfarin either. So just a precaution that's not going to happen often. Okay, then what do you do with the patient? This being Canada, we don't admit many patients at all with this condition. And they can go home fast, but you do have to arrange some follow-up. And I must give you credit for having the most colorful hospital in Canada. It's really cool from the air. So patients hardly ever need admission. In our series, it's like 3% of acute AF patients with a primary arrhythmia need admission, where you just cannot say get the heart rate down. They won't convert. They have significant ACS with ongoing chest pain. By the way, we do not recommend routine troponin testing for your average patient because they're always going to be slightly elevated due to demand, and then that gets you into an endless cycle of repeating troponin. And you know, cardiology will just laugh at you if they had no chest pain or ECG changes and a little troponin bump. At least our cardiologists will laugh at us. That's why we don't call them. And if they're in acute heart failure and you can't get it better, then they may need to come into hospital. If they're on warfarin or you have to send them home on rate control, it'd be nice if they saw a doctor, family doctor within a week. The cardiologists feel they don't really need to see these guys for up to 4 to 6 weeks. Thrombosis Canada has a nice handout. We never prescribe antiarrhythmics in the ED, such as sotalol or amiodarone. And ditto, if you put them back into sinus rhythm, do not prescribe metoprolol or diltiazem. There's no need to do that. What's next here? So bottom line, just to summarize what I've said, I'm almost done here and looking forward to questions. Be sure you rule out secondary causes. It's not often that the patient will be unstable. Go to cardioversion drug or shock if it's safe. For rate control, give proper loading doses up to 3 times in the first hour. Consider procainamide. Start high if you're going electric. Send everybody home and prescribe DOACs. All right. And so I don't think I have to try to convert the choir. Hopefully that most of these folks can go home. So with that, I don't know if I've used up all my time, but I would be more than happy to answer a couple questions.
All right, great.
Or many questions.
Yes, so thank you so much. That was fantastic. We do have some questions. We have a question about, is there a role for pretreatment with calcium when using calcium channel blockers?
No.
Simple answer. Very good.
I'm not familiar with that concept. Sorry.
Okay.
Nope.
And then here is another question. Who goes home on a rate-controlled medication?
So if you decide they're not safe to cardiovert and you slow them down with rate control agents in the ED, then they all have to go home on a rate control agent. Okay. If you convert them, you don't have to send them home on rate control. Hopefully that's clearish.
Well, so it sounds like basically anybody who you can't convert to sinus rhythm goes home on a rate control agent. Yeah,
if you just give them IV DILT and they go slow down and you don't follow with oral, then they're going to be right back where they started in a few hours.
What do you think? So, you know, I frequently see this, sorry, this just occurs to me when I'm thinking about that, is that I see a lot, you know, somebody comes in, they don't get cardioverted. Instead, maybe because they're in long-standing AFib, but then you give them a rate control agent, or like it was too long, let's say more than 48 hours, or the onset was unclear, the patient wasn't able to say, you give them a rate control agent and then they convert spontaneously after getting, you know, then what do? Do you discharge them with a rate control agent, or?
Okay.
Or who knows? I don't know.
That I have not seen personally, maybe because I don't give rate control agents very often. You know, no, I don't think you have to.
Okay.
If they're in sinus rhythm and they hold it, you know, like the odd one is back and forth, that's not good. That means there's probably some medical problem going on.
I see. And anecdotally, I know of another rhythm control. I've discovered a new rhythm control method, which is that the patient comes into resus in very, very fast AFib, and then you do a COVID swab on the patient. You put that thing in their nose and they convert. It happened to me a few days ago. They converted immediately after that.
Okay, you should write that up immediately. Yeah. We'll publish that in CGEM as case report. I love it.
All right. Any other questions from people? And this is your chance.
Yeah.
I think this should be the Lars Grant method, the painful Valsalva.
Yeah.
Painful Valsalva. COVID swab. All right. Okay. I think we got most of the questions in during the actual presentation.
Oh, that's good. Yeah. I mean, you could certainly follow up by email if folks have stuff, you know, they were too polite to question me on, then I'm happy to follow up. But I want to thank you for inviting me back to my alma mater, even if I had to stay at home to do so. And maybe someday we'll be able to travel again.
Yeah, I hope so. I hope so. And then we'll have to have you come in person. We'd be delighted to have you again. Thanks so much for coming. We really appreciate your time. We know you're very busy. And
thank you so much for coming.
Okay, you're super welcome. Have a great day. And remember, the days are getting longer.
Oh yeah, that's right.
And COVID's going to start going down by the end of January.
Oh, great.
Mark my words, it's going to start to go down.
Oh man, I'm so glad to hear that.
And I might suggest that we exchange premiers. Not that it's going to make much difference, but
yeah.
Okay, better not get into politics.
Thank you so much.
Okay, bye guys.
Okay. Bye.
So next up, we have Dr. Turner, who's going to talk to us about ePOCUS wall motion abnormalities. Thank you for being
awesome. All right, can you guys hear me clearly? Perfect. Okay. So great 2 lectures this morning. I hope I can carry on the streak. So let me share my screen. Hopefully this will work. All right. Can you see the screen? Fantastic. All right. So welcome everybody. Like I said, 2 fantastic initial lectures for rounds. And then, so now we're going to go into a 3rd talk on our monthly POCUS Academy. This one on a bit more of an advanced topic, but a topic that is, I think, really, really interesting because we do see it more and more often that we're looking at this. So in about 30 minutes, hope to help you understand when to assess for regional wall motion abnormalities in the acute setting, understand the sonographic territories of the left ventricle and its corresponding EKG leads, learn the techniques of identifying the various territories on bedside ultrasound, and then finally understand how to assess for regional wall motion abnormalities and to learn some of the mimics so that you don't get too confused. So we all see this type of case, a guy who comes in with some retrosternal chest pain. Story sounds a little bit concerning. So of course you get your triage EKG, but it shows a few non-specific STT changes, but more importantly, it's not diagnostic for an acute MI, but the story is somewhat worrisome. So the question you ask yourself and everyone asks themselves is this patient having ischemia or is it non-cardiac chest pain? Are you going to call cardiology right away just based on the story and this non-specific EKG? Are you going to wait for a troponin, being concerned that maybe you're missing an acute infarct? So this is where I think the idea of regional wall motion abnormality assessment really comes into play. It's really the hallmark of echo in patients with coronary artery disease. This is what echocardiologists do day in and day out. But that being said, it's most likely, it's almost certainly the most challenging aspect of echo. And so this is not something that you guys are going to pick up after a day of practicing. You've got to really train your eyes on looking at all these different regions and determine what is normal and what's not normal. So according to the 2011 American College of Cardiology guidelines, there are really 2 indications for doing an echo for patients with chest pain in the setting of coronary artery disease. And that's a patient who's having acute chest pain, who's having maybe a suspected MI, and the EKG is not diagnostic, and you can actually perform the echo while this patient is having chest pain. So that's really an important feature that you're performing this when you're performing this type of echo. The other indication is someone who may not be having chest pain, but you have other features that are an equivalent of ischemia, or you've got some laboratory markers that are suggesting that he's having an ongoing MI. So that's probably the secondary, less important indication. But it's really important to understand that the use of regional wall motion abnormality assessment is really important when they're actually having acute onset of chest pain. Clearly, it's not indicated when you've got your EKG diagnosis of your STEMI. You should never delay the call to the cath lab. You should never delay transport to the cath lab. You've got your diagnosis. Get this person out of your department, get cardiology, and start the process for transfer to the cath lab. So what does the literature say about our ability to perform regional wall motion abnormality assessment? Well, for those who follow the Ultrasound Gel podcast or the blog, this came out about a year ago that looked really, really impressive, saying, wow, we're really, really good at this. And the question was, can POCUS accurately identify regional wall motion abnormalities in patients with an acute MI? And can the culprit vessel be identified? So these were residents and staff performing point of care ultrasound after this patient had gone to the cath lab. So you can see likelihood ratios are fantastic, negative and positive. Wow, we're really good. But you have to remember, the patients doing these, the doctors doing these echoes knew that they were having a STEMI. So the bias is really too strong to determine that, to say that we are actually very good at doing this. If you're looking at any other literature, there's only some retrospective and case series studies that showed that emergency physicians are pretty good at assessing regional wall motion abnormalities in the high-risk patient. which can lead to earlier revascularization. So you have to take that into consideration. By the way, Jake, if there are questions, I don't have access to the chat, so just interrupt me anytime. I don't know if there are going to be questions to let me know, okay?
Yeah, the first comment was really just from Dr. Namath saying about if you can see that, or sorry, you can't because that's what you said, that we're starting to use the nomenclature OMI versus NOMI versus STEMI and STEMI. And there's a Rebel EM link in the chat for all of us to look at as well.
Okay. All right. Anything else? Perfect. Okay. So one of the important questions that you will see all the time in your sort of blogs and podcasts and literature about regional wall motion is what coronary arteries are associated with which territory. For those who follow the sort of POCUS ultrasound, a lot of you may see this if you Google regional wall motion abnormality. This comes from Core Ultrasound podcast. I mean, this is a very, very interesting, very nice identification of the territories and the coronary arteries that are associated with each of the territories. But whenever I look at this, I have to ask myself a really important question. Is this what we as an emergency doctor really want to know? My answer to that is, well, not really, because this is more for the cath lab or for the cardiologist to know which vessel is potentially occluded. I think the more important question is, in a patient who's having chest pain, is there a regional wall motion abnormality, and does it correspond to the equivalent changes on your patient's EKG? Because that's really what you want to know. So this is a far more important, albeit simplified, sort of image that you should be, getting in your brain as to what am I looking for in the EKG, and what are the equivalent regional wall motions, and where am I looking for these on my bedside ultrasound? So how do I assess for regional wall motion abnormality? So this, you'll see in a lot of cardiac textbooks and a lot of emergency textbooks. There are in fact 17 territories, but this is not for us. This is for the cardiologist. This is for the echo people, totally not related to us. If you see this, just ignore it and move on. In order to be able to do this, I would suggest that you learn 3 views: your parasternal long, your parasternal short, and your apical 4. All of them are going to provide very important detailed information. If you are going to learn one, I would suggest that you learn the parasternal short at the level of the papillary muscles, because this provides the best, quickest single view of your patient's left ventricle, because it does actually tell you, it's the only view where you see the distribution of all the coronary arteries, and then as a result, all of your important EKG leads. So we're going to go through this a little bit more in detail compared to the other images and views. So if you want to look at your good parasternal short axis view, the territories that you want to recognize is, well, you've got your septal view, which is between the right ventricle and the left ventricle. Right up in the front, that'll be your anterior wall. You've got your lateral wall. Down here, you're going to have your inferolateral wall. Some textbooks or some people call it the posterior wall, but the majority of echo people, cardiologists, emergency doctors call this the inferolateral, and then the inferior wall. So just remember, septal, anterior, lateral, inferolateral, and inferior. So if you take those walls into consideration, then you should easily be able to identify where on the EKG am I going to be looking or seeing abnormalities. So if the septal wall, you're going to be looking at V1, the anterior wall, V2, V3, V4, the lateral wall, V5, V6, 1 and AVL, and then over down here in the inferior, you've got 2, 3 and AVF. So one view, the parasternal short, you're going to have all your EKG leads represented. The only thing is to recognize is at this level, you're not going to see the apex of the heart very well. And so that is one little caveat that you're going to, you have to recognize, and I'll bring up how you go about looking at the apex. I think, like I said, all three views are important. So I want to go quickly over the other two views. The parasternal long axis view, you're going to have two very important walls here. In the septal area, this is the anteroseptal view. So this again corresponds to the V1 to V3 on the EKG. And down at the bottom, this is the inferolateral view. And again, this is going to be your inferior and lateral wall EKG thing. So on your parasternal, just look at two walls, anteroseptal, inferolateral, and then you're done. Now remember that most of the time, you're not going to see your apex of your parasternal long axis. So again, your parasternal short, you don't see the apex. Your parasternal long, you don't often see the apex. So obviously there has to be a way that I want you to be able to identify the apex, and that's where you should also be comfortable with your apical four-chamber view. Just to go over very quickly, the walls there's your anterior wall, the septum, lateral, and inferior. Again, these we've already seen on other views, so it's not as important, but this is the only real view where you're going to actually see the apex of the heart, which you should be identifying, because as we'll see, there are areas of regional wall motion that are good mimics of MI, as well as true regional wall motion abnormalities that occur only at the apex. And so that's why it's important to get a sense as to what's going on over there. So when I'm talking about regional wall motion abnormalities, what are you actually looking for? You want to look for two things. First, is the wall thickening in each territory during systole? And is there inward movement of that wall towards the center? So how do you do it? Well, there's two methods, I think, for us as emergency doctors to look for regional wall motion abnormalities. The first one is really simple. You put an imaginary dot, or you stick your finger on the screen, and you basically look to see if all the walls are contracting towards that imaginary center of your parasternal long short axis view. What I think is actually sometimes even a better method is that you will isolate each territory. Take a piece of paper and block each territory one at a time and look to see if those two features are occurring. So if I look first at the anterior wall, I block everything else. I say, okay, is that wall thickening? Is it moving towards the center? Then I'll block everything except the septal wall. Is it thickening and moving towards the center? Here I'm looking at the inferolateral. Is it thickening and moving towards the center? Here's the inferior wall, and here's the lateral wall. So I think this is a good way, because sometimes there's so much movement everywhere when you're assessing this patient that you're not really sure what is the correct movement. So I would say it's at the beginning, take a piece of paper and actually do this sort of exercise to look at each of the walls to see, is it thickening and is it moving towards the middle of your chamber? So let's look at some examples and see what we see. In fact, this is the example we just saw before, and I don't know if any of you guys caught it. I'm just going to use my cursor to sort of show that everywhere here looks like it's contracting really well. But if I place my cursor right on the inner aspect of the anterior wall, you can see it is not thickening at all, and it's not really moving much. So this is a patient that clearly has an anterior wall hypokinesis or akinesis. So if this patient was having chest pain, right away, you'd go back to that EKG and say, well, am I seeing something in V2, V3, V4 that is corresponding to this echo? And if it does, that's a very powerful tool. Here's an example, another example. Again, we're looking at anterior, septal, looks good, inferior, inferolateral. Yeah, right there. It looks like all walls are contracting towards the middle and thickening. So for me, this is a very healthy looking left ventricle. Here's an example that's pretty clear to, I hope, to most of you, where the inferior, lateral, and lateral views are contracting well and thickening. And there's basically no movement whatsoever, no thickening of the septal and anterior wall. Again, go back to the EKG, look to see if it corresponds to what you're seeing on your ultrasound. And then here's just another good example of a very good, healthy looking left ventricle where all the chambers are very easily contracting and moving towards the center on every single systolic contraction. So if someone was having chest pain and you saw this, this would be very reassuring as a data point saying that this is not, that this is reassuring. All right, and here's another quick example of someone who's got a very important inferolateral. Clearly, the anterior wall and septal wall are working really, really well. Down here, there's basically no movement. So again, look in the inferior lateral walls if this is something that is an acute process going on in your patient. As I mentioned, you should very quickly go look at other views. So we're just going to very quickly look at the parasternal long, and remember just to look at two walls to make things simple. The anteroseptal, inferolateral. So again, think about your EKG. So this is V1, V2, V3, and this is going to be all your inferior and lateral walls. And you can see clearly here, there's some good contraction and thickening up there, good contraction and thickening up there. So those two walls look very, very healthy. Here's a patient that has actually some decreased thickening up here in the anteroseptum, okay? Even the inferolateral, not that great, but it is contracting, it is a little bit thickening, but these are two areas where I'd have to look at my EKG. You can see the apex is very healthy, and that's contracting very, very well, but these two areas are not, and so this is something you should be looking at. Here's another example of a very healthy looking inferolateral, but again, anteroseptal looks like it's not doing very much, very, very hypokinetic. So again, use your segmental approach to each of these walls to determine what's going on this patient. And here's a patient, I mean, you're rarely going to see something so obvious where basically the only movement of that left ventricle is a septum and everything else is basically completely hypokinetic or akinetic. And then finally at the apex, really, I really want you to see this area just so that you can look at the apical view, just so you can look at the apex of the heart. This is a nice, good, healthy heart where, again, inferior, septum, lateral, all looks good. The apex also is contracting really, really well. So this is a very reassuring study. But this is a patient where, this is an echo that you're going to see very, very commonly in patients who are coming in with chest pain, where again, the inferoseptal here, whoops, I'm going to go back. And then the lateral, they look good. And if you had just cut a parasternal short axis through here, you would have said that there is no significant regional wall motion abnormalities. But look at the apex. The apex is thinned out and really not contracting whatsoever. So again, this is something that's going to be an anterior abnormality on your EKG, and this is an LAD for those who really want to know that this is going to be something that you absolutely should take into consideration that you would not have seen necessarily on your parasternal short or your parasternal long axis view. So this is, again, one view to take to sort of learn as well. But if you really want to learn one view and learn one view well, it would be the parasternal short, because as I said, it's the only view where you see all three coronary arteries and therefore all 12 or 11 of the leads on your EKG. All right.
Dr. Turner?
Yes.
We have two comments, actually. The first question is parasternal short for apex? How is it? Is it okay or not so good?
So the parasternal short, again, you can see if you sweep or scan your parasternal short view all the way down to the apex, then you can see apex, but it's not going to be as clear because the movement is actually going to be, or the lack of movement is going to be towards your probe. So you're not going to see it as well as on an apical view. So yes, technically, if you fan your apical short all the way down to the apex of the heart, you should technically see some dysfunction of the movement, but the easiest view would be the apical fourth chamber.
Okay, thank you. I was at a meeting yesterday, actually, and I heard some ED staff from UDM said they were able to convince the cath lab to bring a patient up stat with an equivocal ECG just on the basis of regional wall motion abnormality. What has been your experience? They're at the Jewish, the RVH, or?
Yeah, I mean, we have not necessarily had the same experience of them going to the cath lab, but when the fellow comes and repeats sees what we saw and repeats it, then yes, they will expedite the cath lab. So yes, it has expedited movement to the cath lab based on what we are seeing. What we're seeing, more likely what we see will expedite the fellow or the staff to come and look at the patient. And yes, they will agree. I think most of them still want to take a look at themselves. But yes, we have definitely changed and altered management based on those findings.
Okay, great. And then last comment from Dr. Bake. Can you comment on new versus old regional wall motion abnormality?
So that was on my last slide of the summary. The answer for us is no. Old regional wall motion abnormality will be scarred. And if you're really, really good at echo, you'll see that scar tissue looks a little bit more echogenic than a fresh ischemic area. But like I said, I'm going to say on my summary slide, don't use that. You really, from our level of expertise, you cannot differentiate new from old. Go back, see what they've had in the past, look at previous echo reports or previous EKGs before you make any decision on that. That's a good question.
Great, thanks.
Okay. So just a few important conditions that will mimic regional wall motion abnormalities in patients that are coming in with coronary artery disease. So any dysynchrony of the LV. So if someone has a bundle branch block or has a pacemaker, you'll see that there's sort of a dysynchronous movement of the left ventricle, and that will be a little bit more challenging to identify regional wall motion abnormalities. Any pressure or volume overload from the RV, which is pushing that septal wall into the left ventricle, again, can mimic a regional wall motion abnormality. So you have to take that into consideration. Sorry, anybody with dilated cardiomyopathy, depending on the region that's dilated, again, will be difficult to differentiate the true regional wall motion changes from dilated cardiomyopathy. Two of the ones that we talk about, that we see or we discuss quite often, Takotsubo cardiomyopathy, again, looks very much like what we would be concerned about, someone coming with chest pain and sort of complete akinetic apex. This is going to be not a true regional wall motion abnormality because, as you know, these patients have clean caths. But again, this is not for us to differentiate a Takotsubo from a true apical infarct. You see this, you call the cardiologist immediately for them to do their proper assessment, and if they need to, go to the cath lab for these types of patients. And then patients who've had previous MIs can have LV aneurysms. Again, could look something a little bit similar to what I had mentioned before in terms of a apical akinetic area. Again, look to see in the patient's chart whether these patients have had previous MIs, have they had previous echoes that have shown an aneurysm in the left ventricle. This is not at the level that we should be aiming to differentiate one from the other. So just to finish off, this is a case I sort of stole from Dr. Smith's blog. This is for those who love EKGs. This is a blog that has thousands of different EKGs, and I just wanted to show or present a case that was brought up on his blog site. So this is a 35-year-old, comes in within 30 minutes of onset of retrosternal chest pain. This is his EKG. I mean, not to belabor the point, but his EKG looks pretty normal. And I would expect that not a single one of us would call cardiology based on the age of the patient and this EKG. This was the initial parasternal short axis view, and it's a little bit desynchronous, but not really sure what's going on. But the physician doing the ePOCUS was concerned about one of the regions in one of the territories, and I'm not going to tell you where. But the question was, is there a regional wall motion abnormality? So we look at the different views. So let's look at anterior. Let's look at the septal. Looks pretty good. Let's look at the lateral. It's okay. Let's look. Sorry, that inferior lateral. That's a lateral. It's okay. And then in the inferior, it says, well, it's not really moving very much if you want to look at that wall right here. Again, this is a 35-year-old with a pristine looking EKG. So this guy was having unrelenting chest pain. There was no evolution of the EKG, but they were able to convince the cardiologist to take him to the cath lab, and he had a 100% occlusion of the mid RCA. So again, to answer your question, it absolutely should, in the right hands, provide important information for you as well as for your cardiologist in a patient who's having chest pain and whose EKG isn't really telling you which way to go. Now, I wanted to show you this because this was the last slide on their blog of something that, geez, I really wish we could have. It's called speckle tracking, which is what they do is they can actually map on their machine the walls of the ventricle. And I'll play the clip and it'll actually tell you and show you where the contractions are. And so you can see the nice good contraction here. And there's basically nothing in the inferior wall right there. If you can look at that, which is quite amazing. If we could have that on our bedside ultrasound machines in the emergency room, that would be spectacular. So that's it's another technology that some of the cardiologists use. It's called speckle tracking for that. So to quickly summarize, patients coming in with chest pain, I think with a non-specific EKG changes, I think looking at the regional wall motion abnormality is very, very powerful. It's very specific and very sensitive and can provide an additional data point to determine whether or not there is true cardiac ischemia or not. Again, if you are going to look at one view, look at your parasternal short, but I encourage everyone to practice the other two views as well. But remember that if your EKG abnormality corresponds to your wall motion abnormality, this is a very important data point to add to the patient's history and physical. Of course, you should always, don't just throw away everything else just because you have an ultrasound probe in your hands, because it can help risk stratify these patients who may or may not need cardiology consultation. And again, this is a very technically challenging thing. You should not base your decisions if you can't get pristine images. And even then, practice. And I would not obviously use it as your sole basis to send someone home or ask for cardiology, but put everything into consideration, including your POCUS. And as Mark had asked, differentiating new from old, it's beyond really what the scope is for us in the emergency department. And that's it. So any questions?
Great, thank you so much. We have, actually, I was wondering if AFib would affect your assessment of regional wall motion abnormality, or given it's high up, it wouldn't.
Sorry, what was the question? I didn't understand. If someone is in atrial fibrillation?
Yeah, because you discussed some rhythm or abnormalities that would affect your assessment for regional wall motion abnormality in terms of mimicking CAD with AFib.
I mean, it will, it depends on how fast the AFib is, but if this is a well-controlled atrial fibrillation, then each contraction should involve all the territories of the wall. So unless there's an ischemic basis of a patient's new AFib, someone who's coming in with just AFib and they're coming in with some chest pain should not affect your wall motion abnormalities.
Okay, great. And Jake was just commenting that it would take a lot, the new technology would take a lot of the potential guesswork out of the interpretation of the echo image.
Of course.
But we'll see. I think that's it. Any other questions? Okay, well, thank you so much for being here.
My pleasure. Take care, everyone.
So we are a little bit off time. I think we've had a lot of interesting talks, but I would suggest a 7-minute break. So coming back at 10:20, 8-minute break. Is that okay? Okay, 10:20, we're back on. Oh, oh. Okay, welcome back, everyone. Judith, do you want to start?
Yeah, so it's not stressful at all going after all these amazing speakers and just before Dr. Anton Helman, but I'll try my best. I'll just try to share my screen.
You'll do great.
So here goes. Do you hear me well, Anne-Sophie? Yeah, okay.
Little Ben.
So basically today I decided to present on ED overcrowding. So we'll do a bit of an overview and I'll present a few avenues for solution. I'll try my best not to make this a ranting episode of 30 minutes about admitted patients who stay and emerge, because I really feel there's much more to it and there's a lot of solutions for these issues. So the agenda will be as presented here. So I'll start with a case. Then we'll have a bit of a background story about what's ED overcrowding, what is actual boarding, and what are consequences of boarding in emergency and why we should actually try to avoid it. I'll have a bit of a review of Quebec situation in 2 different regions, just to see how it actually translates in the Quebec's emerge. I chose 2 articles that I found are very interesting, so I'll be presenting those. And at the end, just a few solution avenues. I'll be happy to hear if you tried anything in your own emerge, what worked, what didn't. So hopefully we'll have time. So case presentation. It's a 56-year-old lady who presents to RVH with nausea, vomiting. She's actually known at the GHGH for ETOH cirrhosis. She was recently admitted there and recently discharged. So she comes back to an emergency. She's initially stable. She's put in the resus bay, and nevertheless, there's an appartenance that's sent and accepted. So the ambulance comes, but by the time they come, patient refused to be transferred. There's also an episode of bleeding. So patient hemoglobin comes back at 46. She needs transfusion. And there's a GI and internal med console that's put in. And basically, patient spends 42 hours in emergency before there's another appartenance that's sent and accepted. And she's transferred to the GH where everything's basically up and again. So before we dive a bit more into the ED crowding, we'll look at an algorithm from the time a patient steps into the emerge to the time, I don't know if you see my pointer, but anyway, to the time where he steps out. Thanks, Jake. So entrance and emerge, there's obviously a small delay usually before he or she gets triage, and then depending on the priority level, they'll be assigned either to the waiting room or an assigned stretcher. This can include as well the resus bay, depending on how sick they are. Then from there, there's often a bit of a delay before the ER assessment. Depending on where you work, sometimes the nurse will start to do some investigation. We'll start to send some labs at this point before the ER assessment. If you are in the waiting room, there's a certain amount of people that will leave without being seen. I'm sure it can happen as well from the assigned stretcher area, but it would be a bit more complex. Then the ER assessment, you obviously start treatment investigation, and depending how the patient is doing, there will need to be a decision made about, can this patient go home, so discharge, or will they need an admission? So discharge, will they have a follow-up with their own doctor, or are we setting up an outpatient follow-up? And for the admission, if magically there's a bed available on the floor, they will go up, but often this patient will be boarding for a certain amount of time in the emergency. So what is actual ED crowding? So it's caused by a periodic I'm just going to change my pictures. Periodic mismatch between the demand and basically the supply of resources we have in an emergency room. Often will include staffing and bed space. The American College of Emergency Medicine defined this more as it's the second paragraph. It's when the need for the emergency service exceeds the resource, but in emergency or in a hospital or both. Because ED overcrowding basically is more a symptom of something that's more systemic happening in the whole hospital versus what's actually happening in terms of resource we have in the emergency room. If the crowding increases, you can have inability to appropriately triage patients when you have large number of patients that are waiting in the waiting room. So how do we measure ED crowding? So there's really no gold standard for for measuring ED crowding. Some people have tried looking at ambulance diversion time, ED census, ED occupancy, looking at various boarding calculation, but there's really no gold standard. This is what I put here is the National Emergency Department Overcrowding Calculation Score. They look at the number of ED beds, number of hospital beds, total patients that emerge, patients who are on ventilators, patients who are admitted and emerge, and the waiting times for those admitted patients or in the waiting room. And it basically gives you a score, 0 to 50. They describe it as not busy, 51 to 100 busy, 101 to 140 overcrowded, 141 to 180, it's dangerous, and above 180, it's a disaster. I'm not exactly sure what happens after 180, but it looks pretty bad. However, there's really mixed evidence for this, and the validation is the literature is very poor. So I haven't seen it used really in the literature. So what are the factors that are affecting the ED overcrowding? So boarding is really the practice of keeping an admitted patient for a prolonged period, and it's one, if not the most significant cause of emergency crowding. What is a prolonged period? So in the literature, they usually describe more than 2 hours from the time the admit slip is put in, and the patient can go up. It's really a reflection of a patient outflow obstruction. And boarding and crowding basically have a lot of downstream effect, as you can understand, on morbidity, mortality, patient satisfaction, and quality of care. So we'll dive a bit more into the boarding consequence. Why do you want to avoid it? So first, if we look at the clinical staff, it will increase the burden on them, and it can accelerate burnout. If we look at the actual patients who are boarded, so they can have increased risk, so prolonged illness, worse outcomes for patients who had stroke, cardiac, intubated patient. There's an exposure to hospital-acquired infections. There's a well-documented literature for increased ventilator-associated pneumonias for these patients. There's lapses in daily medications that they have, and because the emergency department staff is really overtaxed. For the other patients who are in this emergency room, there's also impairment to them. So there's ED crowding that can cause delays for this patient who need active evaluation, compromised care because you need to use always or very suboptimal areas in your emerge, prolonged wait time, obviously, and there's increased left without being seen rates. So what are the factors that are actually affecting ED overcrowding? They can separate those three in three things, basically the input, the throughput, and the output. So the input, we're talking about the urgent visit, the non-urgent visits, how many ambulance you're getting, and the fact that your ER is basically a safety net for the population, for the most the patients who are more vulnerable. During the pandemic and even before that, the Prime Minister Legault really wanted to put forward, having first-line clinics, CDE clinics to try to decrease the number of input patients going to the emerge. Also, during the first few waves, we saw a decrease actually in volume in some ER because people were actually afraid to get COVID. So there was a decreased volume, decrease in input. The throughput, it's really our bread and butter. This is a bit the algorithm I presented before, so it can be split in two. So you have the triage where the patient steps in and basically gets triage and the first really assessment. And after that, we're talking about treatment, imaging, what kind of staff do we have, what kind of ratio do we have with nurse, what kind of experience they have, and all the delays that we see on a day-to-day basis in terms of monitor bed availabilities, CT scan delays, there's no Doppler after 3 kind of thing, or the chest x-ray tech is stuck on the floor, so your patient won't have a chest x-ray yet. So really this is the most visible component that we have for ER physician. The output is really what's going to happen after. So inpatient bed shortage, some hospitals have a kind of a capping in terms of how many patients the admitting physician can have, staffing ratio that you have that are limited patient transfer on the floor, limitation from sending back patient to their nursing care facilities, or having difficulty transferring a patient to higher care level like the ICU. So this is really a screenshot from 2 different dates. We'll look at how it actually translates in the emergency room in terms, so here we have the number of stretcher, number of patients on stretchers. So what's the percentage of occupancy? And then we'll have how many patients have been there for 24 hours and how many of them have been there for 48 hours. This was on the Montreal region on December 24th. At that point, COVID was a bit less, it was a bit less than what we see now. So let's say if we look at the Jewish here, so they had actually less patients on stretcher that they could. They were 60% and only one patient had been there for 24 and then 48 hours. However, if we look at, let's say at Saint-Cabrini, they had 38 beds available, 33 patients were using those beds. But however, those patients had been there for 24, even 48 hours. They had 33 patients on stretcher for more than 48 hours. If we look on January 11th at Saint-Cabrini, thank God those 33 patients left, but they still had 6. And as you can see, really the red is really more present. So they were over capacity for in most of the hospital in the Montreal region. Sacré-Cœur, you look here, they had 13 patients, 48 hours waiting. And same thing, I'll go quickly for the Montérégie, but basically it's the same thing. So if we look at the Surroi, so even on December 24, they were above capacity, and that really starts to slow down. Here it doesn't mention like if those patients who have been on stretcher for 24, 48 hours have been admitted or not, but there's definitely a delay there that we want to avoid. And same thing happened, and it's actually even worse on January 11th. So I'll present my first article. It's the association, basically it's an article that was published in 2011 by Singer and al. And they looked at the association between the length of emergency department boarding and the effect on mortality. It was a retrospective cohort study in one site, and basically they looked at every patient who admitted through the emergency room and discharged during that period, which was October 2005 to September 2008. That were included in the study. They overall had 41,000 patients around that included in their study, and the primary outcome was in-hospital mortality. The secondary outcome was rate of transfer of patients to ICU and the total hospital length of stay. They had defined intervals for them. Prolonged length of stay or prolonged boarding was basically more than 2 hours. And their interval was 2 to 5, 6 to 11, 12 to 24, and then more than 24 hours. They had a protocol that was already put in place at that point that if patients were stable, they could be admitted on the floor in the hallway, and then they would stay there and they would not be boarded at that point. So basically what they showed that there was a significant difference between the boarding time and the mortality. So less than 2 hours, there was a 2.5% hospital mortality, here 2.7, 3.9, 4.5, and then 4.5. And there was a significant difference after adjusting for other factors like age, sex, if there was a weekend shift. And then they also adjusted for comorbidity using the Elix-Hauser comorbidity variable. That's all I can tell you about this variable. And then they had basically the same also significant difference for ICU admission, which was 12.4 here in the less than 12 hour, that went up to 15.9% ICU admission for the more than 24-hour boarding. If we look at the hospital length of stay, which was their secondary outcome, here for less than 2 hours of boarding, it was 5.6 days, and then went up to 8.7 days for those who stayed for more than 24 hours. So obviously there's a lot of explanation. I can explain this causal relationship between the boarding and patient outcomes. Like I said before, there's an increased burden for the ED staff. The ED staff, like including nurse, everyone, are usually spending a bit less time for admitted patients because they have understandably unstable patients to take care of. And also often these patients are admitted under an inpatient service team, so they spend less time caring and reassessing this patient and emerge because they're often more busy on the floor. Admitting those low-risk patients to hallway and leaving the sicker patient in ER can increase the length of stay and mortality of this patient because of the higher illness of these patients. Nevertheless, I think that ED patients who are boarded are really at higher risk of negative outcome based on this study. The second article is an article that looked at the relationship between ED crowding and the reassessment of children with critical abnormal vital signs. So again, it was a retrospective cross-sectional study between 2006 and 2009. The patient population was about 10,000 patients who had abnormal vital signs. It was defined as more than 95th percentile per age. And I put here the table with the vital signs that they actually used. Patients who were sent directly to the resus bay were excluded from the study. And there was basically, how it works is that they were putting a patient in a room and there was an alarm that was ringing at the 60-minute mark for the nurse to go reassess them. How did they look at the ED crowding? So they had a few data points. So they looked at the ED input, number of patients waiting to go in the emergency room, ED throughput, so the hourly ED census, which is how many patients they have everywhere in the emergency room, cumulative hours in emergency, and the ED output, the number of patient boarding and how. So here is basically the results. They used a time to event curve and they had to account for the nursing staff ratio because it was shown there was a significant difference associated with delays in the reassessment of these patients. The time to vital signs reassessment, it was an average 84.7 minutes. And basically all of the variables, all the data point for ED crowding was associated with the reduction in ED vital signs reassessment. They looked at the cumulative hour boarding time. So they say, even if it's a small decrease, so we're talking about 2% per 4-hour boarding time, but they still, like, it's cumulative. So let's say you have 8 patients that have been boarding for 10 hours. So that's 80% total boarding time. So they mentioned in the article that there was actually a 40% reduction in vital signs reassessment. They could not identify which one of, like I said, which one of the ED crowding measure was more useful, but patient safety was overall altered because of the crowding in emergency. So I'm just looking how I'm doing for time. So now we'll go a bit more into what kind of solutions we have for the boarding and overcrowding. There's a study that basically looked at having a healthcare provider in the triage. So we're talking about like a nurse practitioner or having a physician assistant that stays in triage. And they decreased the left without being seen rate up to 39%. Also, these healthcare provider that was actually in the triage, they could see patients who need like a rapid assessment. So we're talking about a patient who needs like a medication prescription or some kind of referral, and they can actually start treatment. So I think that was a good option. There's another study that basically suggested many other solutions. So I'll go over them, maybe a bit less the one that are more like based on the inpatient services, but moving borders to inpatient halls. So we have patient in hallway anyway in Emerge. It's just, it's a very crowded space. The staffing ratio for nurse is very poor at that point. And when it's been shown that if you move this patient to less crowded, safer all the way on the floor, there's actually like, it's actually safe, and patients prefer this because it's calmer and the staffing ratio is actually better as well on the floor. Obviously, you have to move patients who are stable, that do not require monitor beds and so on. Here are those two things. Basically, I will discuss them quickly, but they are talk about doing catheterization schedule throughout the week and then doing it early in the morning so that the patient can leave quicker and they don't need to have a bed really maintained for them. Active bed management. So a bed management person who's responsible in the hospital. I think we already have that in most of our hospital, but it's usually a nursing staff that's doing that. And I'll discuss in the next slide an option that was started at Chicoutimi, and I found it's a good idea. Having a discharge lounge. So when patients are actually able to be returned home, they're often like waiting for a Medicare car or a taxi or an ambulance. If they're stable, they could have a dedicated place in Emerge that you have a lounge, and then patient can move there. You can start to clean the room, kind of accelerates the process. Aggressive management, expediting of inpatient discharge, really that's more for the floor, so I won't spend too much time into this. monitoring of bed cleaning turnaround time. I'm not sure how it actually happens right now. Often we hear the clerk, calling for cleanups, especially COVID cleanups during these times. I'm not sure if it's really monitored, but having a accountability could be a good option. It can reduce time for turnaround time. Simplified admission protocol. So in some place, they need a lot of steps. They have to go through a lot of hoops before a patient can go up the floor. Obviously, right now we need the COVID swab and it has to be negative if they want to go on the floor. So I guess right now it would be a bit less useful, but just having simplified admission protocol, they can be admitted directly from the ER without having the staff or the resident come and see them. I think that could be useful as well. And reverse triage. I think we're starting to do that now with sending back patients with CHSLD. It's basically for a disaster situation, a bit like we're living right now, and it's having a system designed to send back patient home or where they live, like in a nursing place, if you need those beds urgently, which is what's happening right now. So specific solutions for Quebec situation. So I don't know, I'm sure there's a lot of discussion about this, but ambulance reeducation, according to patient appartenance, I feel like they're spending a lot of time bringing patient back. So if there could be some kind of, I don't know, identification that a patient belongs to some hospital, I'm sure they would lose less time. Having a primary care co-located in a hospital. So having reserved walk-in slots for ER redirection, if you have P4, P5, that you have reserved walk-in slots so they can be redirected and alleviate the ED crowding. And then same thing for the other way, if they need ER assessment, they could send our patients our way. In busy ER with frequent boarding, so at Chicoutimi, they started to have a ED shift for senior doctors who are taking in charge basically at signing out every patient who has been there for I think 8 or 12 hours, and they are matched with a nursing like a discharged nurse, and basically what they do is really just spend the day trying to have these patients sent home or admitted, but in a safe way. So they're calling the families, calling the nursing staff, physio. They're really it's really a team, including a doctor that's taking care of these patients, so we can reduce the number of patients who have been boarding or have been staying in emerge without being admitted for more than 12 hours. Outpatient follow-up, ED follow-up clinic, outpatient cardiology, medical day, if you want to give IV instead of admission. And on the PED side, they do a lot of nurse practitioner involvement for complex care follow-up. So complex care patients who are discharged, they have a nurse that is assigned to them that's available from 8 to 5 on weekdays, and they really make sure that they have follow-up appointments. If not doing well, they'll take care of that. So I think it would be useful to have this as well on the adult side, but I'm not sure how doable it is. So here, last thing, I promise. So it's basically the same algorithm I presented earlier, but just adding those options that I think at certain, important points will make a difference in the ED crowding and the issue that we're facing right now. So I won't go over all of them because we just discussed them, but yeah, I think it could help. So if I just go back quickly to my case, 56 years old, she basically had 2 GI consult done, 2 IM consult done, 3 MS call, 2 ambulance transfer. So if we had a direct transfer to the GGH, better communication with patient, complex care nurse for discharge, prevent her coming back to the emerge, I think would be good optimization tools. And that's it. This is just my bibliography, so I'm curious to see if you tried any of these or if you have solutions in your own emerge that actually works. Obviously, this is just literature. I've never tried any of those.
Thank you, Judith. Obviously, it seems from the case you presented a good collaboration with EMS would have been a good idea. There's Mark Bake and Will Grad. Maybe Dr. Grad first.
Thanks. And sorry if I'm breathless. It's not from the talk. It was fantastic, but I was on the treadmill, but I was paying attention the whole time. So sorry if I had heavy breathing. So everything you said, it is all true in terms of the factors that go into causing it, and solutions were all good. One thing, that has helped a lot is having the hospital recognize that it's not an emergency problem, but it's a hospital problem. And if I have to think of one thing that is the most significant, I think it's that. And that is the culture of the Jewish, which has done relatively well in this area, I mean, still having its problems compared to other places, is because the hospital has recognized it's not emergency's problem, it's to everyone's benefit to get it solved. And there's many, different ways that that culture has happened. I mean, it has helped that we've had all the chiefs at all the sites are good, but we had a particular chief, and we still do, going back 30 years at our place, has had strong ideas and had a big influence on people outside the emergency department, was able to show data. I mean, if Bernie Unger was here, I don't think he is, he'd probably better able to speak to me, but show data how these certain things get this done, and how it's to the benefit of people, departments outside of the emergency even, to get it done, and to the hospital as a whole. And he had a powerful influence on how the hospital itself functioned. And we've trained now almost all the people that are in other services. They've come through emergencies as residents, and now they've followed this culture. So it's continued on all these years, and they're helping to make our situation better by buying into the fact that it's not just emergencies problem. And to the point, just to make a last point, that I think this has only been during the pandemic, but we have a huddle every 9 a.m. or so in the emergency with the major concerned services, and they talk about the patients that are down there. And the person who leads the huddle, who actually is the final decision maker on the beds, is a surgeon. So even more to the credit that she's the chief of surgery, she meets and she makes the decisions on who should go to surgery medicine, and it takes away the biased feeling that the emergency is influencing unduly where patients should go, when it's actually decided by another person from another specialty. And the hospital has bought into that. They accept that this surgeon will make the decision for complex cases or where there's often uncertainties where a patient should go. So again, I feel the buy-in from players outside the emergency is very, very important, but often very hard to get.
That's actually really interesting. I didn't know there was like a higher part that was deciding who was going to get admitted. Interesting.
And Dr. Bake?
Thank you for this presentation. I think it's a pretty good summary of most of the stuff you're going to find in literature. I think that just to follow up on what Will said, what we did at the MUHC that has helped is have a clear admission algorithm, and that algorithm essentially is meant to deal with the complex patients who fall between the cracks or fall between services, like who gets admitted to oncology versus medicine, who goes to surgery versus medicine, that kind of stuff. And some people do disagree with the algorithm, and unfortunately, one of the things that we are struggling with is that some people decide that, oh, well, this should really be a medicine patient, but they're assigned to surgery for resource utilization. Just one last comment, 2 comments. The first thing is ED overcrowding has been a problem and well known for at least 2 decades or 3 decades, going back to when I was chief. And people have to realize that there's no single solution that is going to work. If there was one magic solution that would work, we would have found it a long time ago. And the reality is that you adapt different scenarios to different people in different settings. Because they will change. For example, if you look at the MUHC, it was built without a discharge lounge on purpose, on government recommendations. So the inpatient floors have essentially no space where they can put a patient waiting to be discharged and be picked up. It just does not exist. And the government actually made sure that it would not exist. And they've made no provision for overcapacity because they did not want the hospital to start admitting patients that they did not feel should be at the MUHC and that kind of stuff. So they've shot us in the foot in a pretty significant way when they did the design of the building and the plan. I think one of the things that we tend to miss when we look at overcrowding is our own contribution to the flow and the exit of patients. We tend to use resources without thinking about the impact on the emergency. For example, if you look at people who spend the night in the emergency to do a service, they walked into the emergency, they need to cease a gastro quickly. So we want to have it done during the emergency visit, then we just keep them in the waiting room all night to be seen the next morning, whereas they could come back the next day and that kind of stuff. So we need to also look inside at our own workflow and how we manage our patients, how we make decisions, and what our patient trajectories are, and how we organize our own work in terms of speeding up, because overcrowding is a mathematical equation to some extent of how many coming in and how many going out at any given time. And in between, there's a trajectory. And we manage a lot of this trajectory for patients to get discharged home. And that's one area where people have to work and think about.
Thank you. Interesting comments.
Yes,
I'll stop here for the Jake. Go ahead.
I was just going to throw on actually just given that Dr. Bake was just speaking, and there are just a couple of other comments, but given that Dr. Bake is also in the health informatics field, and Dr. Nemeth commented on if artificial intelligence is being used at all in this field of overcrowding.
The answer is currently no, most places. Possibly yes. Where AI can help is in terms of speeding up and streamlining the trajectory. So essentially anticipating admission, that kind of stuff. We sort of started working internally at an algorithm that would actually allow you to predict who needs a bed and who does not need a bed. And you can make that prediction fairly early on during the length of stay, and you can readjust depending on how data comes in. So you know that somebody who comes in with a sodium of 110 is going to need a bed. The problem that we have is that the sodium 110 needs to be assessed, and then there's a consult to internal medicine, which takes anywhere between 4 and 6 to 12 to 18 hours, depending on the volume. And then only when internal medicine decides that the patient needs to be admitted, which is obvious to everybody, will they put in the admit slip, and then there's a whole process of finding the bed. Clearly, if as soon as you know that sodium 110, you had a process by which the bed management knew that this patient is going to require a bed in parallel to the rest of the assessment, by the time the medicine decides the patient will need to be admitted, the bed could be available. But what happens is that bed finding exercise in itself takes 16 hours. So you just add up all of these steps one by one, and then you lose a lot of time. So AI can help at that level, and it can also help in terms of streamlining the way that we work. There's a lot of artistic flu in terms of the way people work, a lot of differences, and you guys as residents can appreciate that, one staff does it one way and the other staff does it the other way. That is probably not helping our flow and our overcrowding. So that's the short answer to the comment.
All right, thank you so much. Thank you, Judith. And there are, as a great segue, there are comments from our two very exciting guest speakers coming up just now from Dr. Thoma and Dr. Helman. Dr. Thoma just mentioning that in Saskatchewan, they just built a new ED without a waiting room, but all beds were filled very quickly, and they ended up needing to make a small lobby to form a waiting room within a few hours of that happening. And Dr. Helman has mentioned that Grant Innes has written some fantastic thought-provoking articles on ED overcrowding, and he is open to being emailed about that if you have more questions. Okie dokes. So I think we'll move on to the final session of the morning. So I'm very excited to introduce this panel discussion amongst experts about FOAMED. I'll give brief introductions just because I don't want to take away from the discussion. So to start, we have Dr. Anton Helman. I believe that most of us here have listened to his podcasts like EM Cases. Brief introduction to him, if you haven't heard of him, he's an emergency physician at North York General in Toronto, assistant professor at the U of T, Division of Emergency Medicine, and the Education Innovation Lead at the Schwartz-Reisman Emergency Medicine Institute. And he's the founder, editor-in-chief, and host of Emergency Medicine Cases. Next is Dr. Brent Thoma, who I've known for quite some time, actually, one of my initial mentors at University of Saskatchewan. And I think a lot of us also make use of his website for, anywhere from using the Crackcast podcasts to general resources on a variety of different topics in emergency medicine. I'm basically, just going to do a quick intro as well for him, as he's a medical educator and researcher based out of the University of Saskatchewan. He's an emergency physician and trauma team leader. He founded Boring EM as a resident and then designed the Canadian EM website. He is currently the chief executive officer of that website. Finally, unfortunately, we also had a third speaker named Dr. Kyla Kainers of EM Sim Cases. We were excited to have her, but unfortunately, due to the COVID situation, how it is ever changing for all of us, family obligations required that she is unable to join us for today. So that's unfortunate, but we're still very happy to have our two guest speakers. So generally how this will go is I'll somewhat moderate the questions. I have an initial list of questions, and we'll, in essence, it's question and answer with the panel, but please feel free to write questions in the chat or even speak up if you wish. All right, so Brent and Anton, are you ready to go? Okay.
Yeah.
All right.
Thanks so much, Jake.
Awesome.
Hi, Brent.
We haven't seen each other in a really long time. Hi, Anton.
Nice to see you, man.
All right. Very exciting. Okay. So the first question is I'm going to give you the chance to say what do you do and how did you get into it?
You can go ahead.
All right. All right. EM cases. So for those of you who don't know EM cases provides FOMED, and really it's all centered around this thing called a learning system. That's what we like to call it. So what's this learning system? Well, first it's multiple media. So there's podcasts, there's blogs, there's email blasts, videos, infographics, there's quizzes, plus we have courses and conferences which aren't foam. We try to do everything we do with the sort of leading educational principles in mind of spaced repetition and multimodal learning. So that's why we offer so many different avenues to learn. But the core of EM Cases is the podcast, only because it's, I think, the most fun, it's the most intimate medium, and it's probably the most easily accessible medium that you can learn while commuting or jogging or washing the dishes or what have you. So we have 4 different podcast formats. We have main episodes where I interview 2 experts for about an hour. We have EM Quick Hits, which are a bunch of sort of 5-minute segments for people with short attention spans. There's the Best Case Ever series and the Journal Jam podcast, where we do deep dives into the world's literature on very specific research questions. So with the spaced repetition and multimodal learning in mind, what we do is we send out these email blasts called Just the Nuggets, where we break the show notes into little chunks. We email them out every 2 days at about a week after the podcast is released. And then we have rapid reviews videos of the podcast as well. And then our quiz vault, which has about 10 questions from each of the main episodes. So basically over time, you might listen to the podcast on heart failure, then you get some emails of the show notes and chunks. You might watch a video, and then you might take a quiz. And by the end of that, you've basically got down, hopefully you've got heart failure down pat. So currently there's about, I think it's about 200,000 podcast downloads a month, about 15 million over the last 10 years or so, and about 250,000 page views a month on the website. It's about 3 million this past year. So that's what we do. And then I think the second question was how we got there. But maybe I'll let Brent talk about what he does, and then we can talk about how we got there.
Sounds good. Yeah, mine's a bit of a merger, I think, of those two. So I think it's probably easier for me to explain sort of where we came from and how we got where we were, which is a little bit of what I did as well. And then we bump back to you, Anton, for the other half. So when I was a resident, I think I was a second-year resident, and I did my Canadian in-training exam, which I know you are all very familiar with. I didn't do well on, I can't remember, geriatrics, dermatology, like ENT or something. So the topic areas that I didn't find, I'll say, probably very exciting at the time, although very, very core to emergency medicine. And so my program director is like, what are you going to do about that? I'm like, I'll start, like, I don't know, putting stuff together on these boring topics. Hey, maybe I'll make a blog out of it. And so I did. I like made a little blog out of it. It was called Boring EM. I started that in residency, and it was just sort of at the start of when foam started, and or was being talked about a little bit more explicitly. And it got a really good reaction. My first post was on interpreting urinalysis of all things. So not, again, the most exciting things that we do, but that it got engagement because I think most of the content online at that time was was the Scott Weingart, MCRIT, sexy critical care stuff. And there wasn't a lot of other stuff being done on the other aspects of emergency medicine. That went on for a few years. And then we amalgamated our website with a couple of other Canadian foam providers, and put together a single website called Canadium. And so that launched just in my first year as faculty in January 2016. And my role has really transitioned to being like, oh, I'm the person that writes the stuff and the only one that is involved with the website, to being, I'm more try to provide a platform for a small community that we have that's largely composed out of students, residents, and junior faculty who have ideas and things that they want to do. And that's what Canadium is, I think, a little bit more to me right now. So I provide the support, make sure there's funding to get things going, some expertise and assistance. And we have a big team of people that we meet on Slack, and we try and put things together. A lot of that is ad hoc. Often there will be people like the Crackcast folks. That was one of they had their own site originally, but they weren't really excited about the site. What they were excited about was the podcast, and they wanted to focus on the podcast. And I'm like, well, we could host your podcast for you, and you could publish all your stuff on Canadium, and then you could just do it that way. And they were happy about that, so they kind of moved and amalgamated to Canadium. Similarly, there's been other series that different medical students or residents have started over the years, and it's either been podcasts or blog post series, and that they put together, and we provide them with a platform as well as some expertise, some support, and some review so that they can get their stuff out there in the same way that I did as an emergency medicine resident, but I guess with a little bit more training wheels. I mean, I started, I didn't know what I was doing. I didn't have any support, and I hopefully and fortunately didn't get myself in too much trouble, and kind of was able to navigate things. But that's a little bit harder to do these days, I think. And there's a lot more established things. So to start something new on your own is really hard right now. And I think Canadium provides an entry to that for a lot of junior folks, and also gets a lot of opportunities for us to do cool new things. So we have collaboratives with the American Heart Association on making infographics. We've worked with several other different organizations to promote aspects of their research. And I mean, we got a pretty thriving infographic community. The blog posts sort of come as they come in. And then our podcast with the Crackcast crew is one of our main products. And I think, Anton, it's been interesting hearing you talk about some of the things that you've evolved and like the ways that it becomes more multimodal learning, because I think we've seen some similar stuff with like things like Crackcast. So Crackcast is available on the website as a blog post. It's also a podcast. And then we have flashcards that we've created for those as well. And like that's a really intended to be a very much study resource focused on a Royal College residence requirements. So trying to move towards that, because I think that's very much in keeping with education and how education should work. But that's sort of my story about how I got into it and what I'm doing now and how my role has shifted over the years, and certainly very different, I think, evolutions of our projects for myself and Anton based on that. But Anton, do you want to jump back to how you got into it a little bit? Because I mean, you didn't address that as much, but.
Yeah, sure. So, how we got there, I guess there's two separate questions. One is how we got there, and then how I got into it. I got into it, it's a little story. I was just sitting around the dinner table with my brothers, 10 maybe, somewhere around there, 2009, I think. And I had been listening to MRAP, which I think was pretty much the only podcast around in 2009 for emergency medicine. And I had a background in music, and I was talking to my brothers, and it just so happened that one of my brothers is a business guy and the other one was a web designer at the time. And I said, I could probably do a podcast like that. They both said, you're kind of crazy. I said, well, what if you guys help me out? Like, you set up a business plan to my one brother, and you set up a website for me, and then we just kind of try it out. And it took a lot of cajoling, but they finally said, okay, sure, you're my brother, little brother, I'll do it for you, very kindly. And then the interesting thing was, I asked some of my colleagues what they thought of the idea, and everyone thought I was totally crazy. The only person actually was Walter Himmel, who was the only person who was really kind of a mentor and helped and kind of supported me in doing what I do. And Brent, I was exactly like you. I was flying by the seat of my pants. I had no mentors. I think today is like a totally different kind of scene. There's mentors everywhere. So there's plenty of opportunities for residents to get involved and get mentored. So that was kind of how it started. And then in terms of how we got to where we are now, I think it really boils down to three things. I think the thing is that you need to get good at one thing. So for me, I had this background in music recording engineering, and podcasts seemed to be something that I was interested in and passionate about. And so for me, I got really good at producing podcasts. And so I think if you're going to get involved in foam as a foam producer, I think you got to start by concentrating on one thing that you're very passionate about. Then the second thing is how we got here was, as Brent was saying, is building a team. You can't do this alone. The culture 15 years ago in emergency medicine was not team-based by any stretch of anyone's imagination. The whole idea, you guys have kind of grown up in this culture of teams. So back then, again, you were kind of on your own. Now it's great because you've got so much opportunity to be part of a team, and it's almost impossible now to, I think, get a successful foam thing out there without building a team. And then the third ingredient, sort of, in terms of how EM cases sort of got there, is consistency. Consistency with putting out material. So every week or two for the last 12 years, we've had something come out, and to be sort of consistent so that the people who are consuming the stuff kind of expect what's going to happen next. And if so it's very hard, we all get busy sometimes, and that comes back to the teams, is if you can't do if you're too busy to produce something, then you have someone else on the team take it for you. So that's about it. It's really three things in terms of how to kind of build up a foam platform. Is, I think, to start, you've got to be passionate and concentrate on one thing that you're good at, and then building a team, and then the consistency.
Great.
I guess that given you put out so much material, you're saying like every week there's something that comes up. I understand that you're working in a team, and that's a major part of why it succeeds. However, how do you find it interacts with your clinical duties and personal life balance?
So I think that's an interesting question. I think Anton and I have kind of come at this in terms of the sustainability of our work in quite different ways.
We're both totally insane, Brent.
Well, and less so if you understand how I think my life works. But I'll note I don't produce so much content anymore personally. I more like supervise and support, and that's sort of one of the ways I mentor students and help. And then I've got a bunch of other people on my team that have taken up like pretty big roles with the website to shepherd some content in. But honestly, whereas Anton has found, I think, and you can talk about this a little bit more, Anton, some funding and ongoing ways to support some of his work. Mine really was by integrating scholarship into it and then getting paid for that, which is also not necessarily an easy thing to do in the current emergency medicine environment. But I have funding for 0.5 of FTE in Saskatchewan, which is paid at about 90% of a clinical rate, which is kind of crazy. If you don't go looking for that now, you will not find that. But that is what I have. So I have basically Yeah, 0.5 FTE at 90% of clinical FTE to focus on research and scholarship. And a lot of my, historically more so than now, a lot of my publications and research relates directly to my website content or uses my website or my websites to do those studies and to be involved in that community and to give me the credibility to do that kind of research. So I spend some time certainly on Canadian, but I also have funding for some of that time. And it is very flexible as long as I publish papers and bring in some grants. It is very flexible regarding what that looks like. So that's kind of how my time gets supported to do some of the work that I do. And increasingly, we've been looking at bigger grants and collaborations which actually bring money back to our website as well. We put some advertising on it, so there's never been there's no drain. In fact, I think probably our website produces, just in advertisements alone, twice as much revenue as we need to run the website. So we probably got to cut down how many we have on the website right now. And then again, my time is supported separately. And then we certainly have a lot of volunteers whose situation is different depending on where they're coming from and what they're trying to get out of the project. But like, that's how it works sustainably for me. If I didn't have that academic support, I don't think I could spend as much time as I do just sort of not getting paid on the website side. Anton?
Yeah, so it's sort of a multi-pronged question. One is how you find time. So A is the team again, and just like Brent, I've sort of offloaded a lot of the work that I used to do myself on EM cases onto a team of we've got about 20, 25 people on the team now who do everything from editing audio to the show notes to writing quiz questions, and I sort of oversee all of that. You know, I used to spend a ridiculous amount of time, I don't know, 30 hours a week or something on EM cases, and now I spend more like 5 hours a week. So it's totally manageable. And as Brent was saying before, these days, starting your own foam platform from scratch, you have to be a little bit insane, like Brent and I were. Sorry, Brent, but we were a little bit insane when we started these things. And so there's so much opportunity to join an existing platform already that's totally manageable. And then if you want, you can go out on your own. So as an example, one of Brent's mentors, Michelle Lynn, she mentored not only Brent, she mentored Salim Razay, who does Rebel EM. She mentored Anand Swaminathan, who does everything, and many others. And so I think it's key to find a mentor. And then the other part of the question in terms of finding time is the financial thing. And yeah, Brent's right. I do get financial support from a nonprofit organization called the Schwartz Reisman Emergency Medicine Institute. And their mission is to improve research and education in Canada. And so I've cut back a little bit on my shifts in order, so that does provide some financial support. But again, I don't think that's anything that anyone who's interested in starting a platform really needs to know about, because again, there's so many existing platforms to join at first that that's nothing that you kind of need to worry about. And then the third part of that, in terms of finding time, it's just being smart about your time. You know, I prioritize my family and my health over everything, and so I just make sure that I have those things first, and EM cases and my clinical work second. And I'm a musician. I play music. I go mountain biking. I do all kinds of things. So it's definitely possible.
Great. Leapfrogging off of that, in terms of, so now you've got your platform, and now I understand that now you have teams under you, and it's an amalgamation of things. But when you're about to make a new episode or a new entry, how are you choosing to do whatever topic you're going to choose to do? And also that leads into a subsequent question. What information are you using to make the subsequent podcast or post? Like, are you using just studies, or are you using more case studies? So how do you go about those things?
So I can jump into this. I mean, so for me, again, my role has shifted such that I don't actually make a lot of content myself. I more oversee that content, and a lot of those. So really, it comes from honestly the people that I'm working with that have an idea that they're really excited about wanting to do. So usually, I mean, one example was I had a student on a shift, and residents, you won't appreciate this, but when you've been staff for, I haven't been staff in like 6 years out of residency, or so 7 now, I guess. But like occasionally a resident or a learner will be like, oh, could we do this? And I'm like, is that a thing that other people do? I feel like I'm fairly up to date, but I don't work with my colleagues anymore. I don't know what other people are doing. So sometimes then residents come up to me, or medical students come up to me, I assume that they learned that from someone else, and I'm probably missing something and I want to learn about it. So that's been the initiative for some, if I'm working with a student and they come up with something like that, that makes me think, I'm like, we want to do a blog post on that. You want to do a resource on that, an infographic on that, something like that. That's some of them. Some of our content is driven by other organizations. So we really wanted to help translate the American Heart Association ACLS update back in, I don't even know, 2018, 15, somewhere 16, somewhere in that range. And we made a bunch of infographics on our own. Subsequent to that, they contacted us saying, hey, that was really good. Could we work with you to do this in the future? And we made a contract with them where they pay Canadian to produce some of that content. Other stuff like the Crackcast guys, when they came, they're like, we want to do a podcast on every chapter of Rosen's during our residency. And I'm like, you guys are truly nuts. That's crazy. I mean, I don't believe that that's actually going to happen, but how can I support you to help make that happen and take off some of the load on the website side of things and that kind of thing? And that was really them driven. One of our other series we've had that was really cool, I thought, was a medical student who I worked with wanted to, look at historical art and then comment on the medical aspects of things that are happening in there, what, could be episodes. Called the Arts PRN series. And she put together tons of these blog posts looking at this like historical art that I've never seen before and the medical things that are happening in it. We've got another guy who's like, I want to write about the medical aspect of Game of Thrones episodes. And that's where that came from. So he's got a whole series on like, how the medical aspects of, stabbing when Jon Snow gets stabbed a bunch of times, hypothermia, poison when Joffrey gets poisoned, and he's gone into other shows now, some of which I don't even watch, so I don't really know what's happening with those blog posts right now, but they're just kind of fun things. And honestly, really, we're inspired by the people in our community that we try to give support to. So our role really now is we need to make sure that when the learners are putting out content, which is often a lot of this has been driven by learners or helped by learners, we need to make sure that when it gets out there, the reaction of our online emergency medicine community is not going to be, what the hell are you talking about? Or a lot of pushback. So we try to put in some sort of rails for people to support. So we have often reviewing with the staff situation. So those learners putting together that content, review their case with like an attending in that area who has some expertise, so they can comment on it, support it, be there to defend some of the stuff that's put out there, and also just make it a better learning experience for the learner and a better resource for everyone else. So we've published on that reviewing with the staff process, but that's kind of where the ideas come from. Really, they're coming from our community. We have done a couple studies on like trying to identify a gap analysis of foam, to kind of get the areas that aren't really covered, but I'm not sure how much uptake there has been in sort of filling in the content areas that we don't have. There's been a few papers published though on certain areas that are like less represented in foam that we have out there. I can link them in the chat. Anton?
Yeah, Brent, you mentioned community. I can't overemphasize how important the notion of community is in the last 2 years, where the notion of community has almost been lost in the world with sort of the rise of, I'm going a little bit off topic here, but individualism and everyone's angry at everyone and extremism and everything. That's one of the great things about foam, I think, is a community. And it's the community of, there's Brent's there's Brent's community of Canadian EM, there's my community of EM cases, and then there's the greater emergency medicine community. And I think that's one of the things, and tying back into, how do you find the time for this? It's so satisfying being part of a community and doing work as a team, as a community. So anyhow, I just wanted to put that out there, that I think especially now, being involved in some sort of community, whether it's a micro community like Canadian EM or EM cases, and being involved in your emergency medicine community, I think is just so key to having an enjoyable career in emergency medicine, rather than just taking each shift one by one, each patient one by one, going home and forgetting about it. So that's a bit of an aside, but the question was, how do we find our topics? It's somewhat similar to Brent. There's basically 3 ways in EM cases. There's probably some more, but the basic ways for EM cases that we find topics are, one is if there's an expert in something. So everyone wants to hear what the world's leading expert, their perspective on whatever topic they're an expert at. So if there's someone local, or there's someone I hear about who is a world expert at something in particular, then I'll just ask them. And so whatever topic they're an expert at, that's how the topic comes about. Then it's often just some big new study comes out, and so we'll choose that topic and integrate that new big study on that topic. And then the third way is just getting requests from EM cases listeners and users. We're about every couple of weeks I get a suggestion for a topic. And then I guess the last thing is, as Brent was saying about the gaps, was that ultimately I would like to cover every topic there is in emergency medicine on EM cases, so that it becomes sort of this vault of, you can go to anything for emergency medicine. And I get one of the things about foam that you could probably argue is a slight disadvantage, is that foam tends to choose topics that are exciting or new, or that someone doesn't know anything about, that are intriguing and engaging. And there are lots of topics that are quite boring, although Brent seems to have covered most of them on boring EM. And so, those are covered in a way, but there's still a lot of topics in emergency medicine that you can't really find much on foam. And so there probably is a little bit of a gap there. And one of the disadvantages perhaps of foam is that foam engages learners so well, and part of engaging learners so well is choosing topics that are really interesting and engaging. And so we might be missing out on some stuff there.
All right, and we can go with that. A question that kind of came up is, we're talking about where things are at. I feel like there's a lot of directions to go here, but where do you think things are going in the future? Could it include a lot of boring stuff on top of, potentially I was interested, Dr. Kyla Kainers isn't here, but, maybe even virtual reality simulations or for other learning opportunities. But I'll let you talk more about where you see the future of foam.
Maybe I'll go first on this one, Brent. I think there's 3 trends of where foam is going. One is that there's this sort of blending of traditional foam and of traditional resources and foam resources. I think increasingly there's going to be this blurring of them. And for example, there already has been a blurring of foam and traditional resources. Pretty much every major medical journal out there has a podcast now. And on the flip side, the quality foam blogs borrow a lot from journals in terms of how to reference things properly, just as examples. So that's the one thing, is I think that there's going to be less of a distinction between foam and traditional resources, because I think everyone's kind of borrowing from each other. It's all going to kind of blend together. The other trend is that the sort of market, for lack of a better term, is kind of saturated in foam. And so again, it's hard to start something new because there's so much content out there. that I think what's probably going to happen, and it probably has happened already, is that the 10 or 15 or 20 main foam resources that are the most used are going to kind of become established as the 10 or 20 places, because it is becoming increasingly hard for someone to start out, and it's already so the market is already so saturated. So I think that's another trend, is that those few, for good or bad, those few platforms are going to kind of be the entirety of foam. Then the other thing that's the trending is POEM with a P. So instead of free open access medical education, there's the paid open access medical education. So as far as I know, there are two. I know Scott Weingart went to a paid model in August, I believe it was. And Rob Orman, who did ERCast, which was foam for a long time, I think he charges for that podcast. And this goes back to what Brent was saying about getting funding. So Brent and I are both lucky that we have funding, but as Brent was saying, it's very hard to get funding like he has. And same with me, it's very hard to get funding like I have. And so I think there's probably going to be a trend to, and because it's also blending with traditional models more, I think there's going to be some more paid models, but we'll see what happens, because, you know, Scott was one of the main sort of drivers of foam at the beginning, and you could consider him sort of one of the leaders of foam, and now he's not foam anymore. He's partly foam, but he's went to a paid model. So we'll see. Time will tell to see if people follow in his footsteps. I'm curious what Brent thinks about that, actually.
You know, I think that's a great summary of some of the trends. I think, like you said, what I've seen over the years is consolidation a little bit as well. Like, again, it's before it used to be everyone just could start their own new website. The barrier to entry is so high, as mentioned by the chiefs there. Like, there's so much content out there to even, you know, build a platform, unless you're really in an innovative area, or honestly, you're not in emergency medicine. Because while I can say this in emergency medicine, I don't think that's true for internal medicine subspecialties. For like radiology has some pretty big guns, but they never had the little ones, it seems like, as much. But other specialties or subspecialties, I still think there might be some niches there, but those are certainly smaller. And I think so. Yeah, I think we're going to continue to see that. More broadly, like Anton said, the blending, like all of a sudden, where historically you would never have the journal doing this online free stuff, and you would never have the online free stuff doing this journal stuff. It's almost like these disruptors have sort of many of the things that they've been doing. So the foam websites that were sort of disrupting that research and traditional publication base, because they could do it faster, they could do it quicker, they could do it more accessibly, they could do it cheaper. Again, we're seeing those things, so things merge in a lot of ways, like Anton mentioned, but not only on the journal doing foam stuff, but also the foam stuff doing journal stuff, like charging. But also, don't forget the Bubbles is a pediatric emergency medicine blog. They have conferences and stuff now. They have digital object identifiers on all of their articles, so they can be cited really easily in informal journals and stuff like that, which is again more of a journal activity. And I think that's going to keep happening. The acceptability of these resources now, I feel like, I mean, honestly, when I was in training, if I was like, oh, I heard that on a podcast, like immediately dismissed by some of our more senior people. But now I feel like, I don't know, at least, and maybe it's just because it's me, but I almost feel like it's kind of like, oh, which one? Okay, like who was that was talking about that? There's almost some personal credibility that people have built up, as well as some of the websites are a little bit more respected. Like in the US, Academic Life and Emergency Medicine is like a very well accepted resource and coordinates all sorts of things. And there's other websites that reach that now. So I think that's going to continue. Centralization of resources, like I don't know, and also content, like historically we've done this, everyone doing their own thing. And I think we're seeing a beginning of a trend to maybe like everyone doesn't need to do everything. I've always said in medical school, like, why do we need to have like a heart failure lecture at every single institution of variable quality? Like, is there not one real good expert who's really good educator who could do that as well? And then we could spend more time doing more interactive things. Because the bottom line is didactic content delivery, like that needs to happen at some point, but it's not particularly engaging and it doesn't result in a lot of retention. But it is a way to get exposure. But where you need to build on that is the spaced repetition, the retrieval of practice. You need to get on, actually, Anton has a spectacular podcast that I reference all the time with Jonathan Charbonneau on how to learn and study that kind of goes through all of these different practices that are good. So maybe I think we need to centralize, we are seeing the centralization of things, and hopefully that's going to be met with at the local level, more of that interactive, engaged content delivery and discussion. So national rounds is, I think, a great initiative from CAPE, where they're putting together this national session with these national experts. How is that going to be integrated ultimately in residency programs and continuing professional development, where people are leveraging those things? They don't have to go do all that work, but their work is devoted to more interactive stuff happening on the ground. Kyla's website, EM Sim Cases, you guys may not know this, but I almost guarantee you that the majority of your simulation content in terms of cases is sourced directly or modified from the cases on her website. And that's, like, again, another example of centralization of the resources. So you're not at every individual website reinventing the wheel of coming up with sim cases for every thing that you need to cover in your program. This is being published now centrally online, and we're able to all access that and grow from it. I think that's going to continue to happen. And I still think there's tons of opportunity for new people to get into this area. Just, you got to figure out what your niche is going to be and how it's going to be different than other people. So I don't know, Anton, I really agree with a lot of what you've said. Those are just my comments on some of those. So really, to summarize it, greater blending and less explicit black and white between what's foam and what's an academic resource, consolidation, and sharing between sites and centers regarding that.
Yeah, Brent, I totally agree about having, the best heart failure lecture in the universe being in one spot that every medical student and resident goes to, and then you can have like a PBL sort of session afterwards discussing the intricacies of it. I think that's a great way to learn. The flip side of having the central thing, and I think this is especially true for podcasts, is that there's two aspects. One is people want to hear different perspectives, and that's one of the great things about foam as well. Sure, journal articles have, editorials and opinion pieces, but I think foam's done a very good job at giving different perspectives. And I mean, that's one of the reasons why I set up the main episodes the way I do, is having two experts at something, and then they might have a disagreement about something, you get different perspectives. And so, yes, for core material, I think it's good to have everything in one place, and that might be a trend that's happening. But I think that there will continue to be a need and a want for different perspectives. And I think especially, I think the podcast medium is especially good for that. And I think that's actually the best way to learn, is to understand all the different perspectives and then integrate those into your own practice. And so I think that's here to stay. The other thing about podcasts is that it's such an intimate medium that people will like a podcast, even though they might not be willing to admit it, but they'll like a podcast just because they like the personality of the host of the podcast. Or the opposite might be true. They might despise the personality of the host of the podcast. So it doesn't matter what content they have, for whatever reason, they just don't like the host. And so they'll never listen to that podcast. So there's all these intangibles that come into the equation that I don't think we can sort of measure, and I don't think we can really predict. So I think it's kind of a blend of those things going forward.
Okay, great. This has spurred some questions from the chat group. So To start, Dr. Grad was wondering if you have advice to residents on how they can more easily integrate foam into their learning. I have a follow-up question for this as well, but maybe to start, how to integrate it more into our learning.
Brent, tell me that one's you, because you're like an expert at this. Canadian EM has so many great posts on how to do this, so I'll leave that one for you.
Oh yeah, no, and I mean, being involved in a residency program quite closely, I certainly see different approaches to this. I think from my perspective, ultimately, what's going to work for one person isn't going to work for everyone, and I don't think there's one true and correct answer. But the bottom line is that learning is better when it's active. So I think what I would recommend for learners and how they integrate foam into their life, they need to figure out. They're going to need exposure. You need passive exposure to content. You're going to need multiple exposures to content. I talk to all the residents like, I feel like I read something and it's just like I forget it the next day, and they think there's some weird person that happens to. But that's not the case. That is everyone. Everyone is like that. All the smart people you think are really smart are like that too. The bottom line is reading something once, be it on a blog post or a textbook or anything else, is never going to teach you something or have you remember it in a really tangible way. So what you need to do from that is have spaced repetition, have retrieval practice, and really be active in the learning that you're doing. So that's a general overview, and I think that applies to all of education. Then the second part is, what resources are you using and how are you integrating that into your life? Some people have told me they really love Crackcast. It covers all those chapters. It gives them an overview. It's an easy way for them to review it. It's still a passive learning modality if you just listen to the podcast, but it could be part of a spaced repetition practice where maybe, oh, hey, the months that I'm going to, that you have Rosen rounds, you're also going to listen to the Crackcast chapters that month while you're reading those chapters. That would be a good way, I feel like, to integrate it. And then you're going to look through the quiz questions. You're going to actually add the flashcards from the Crackcast into your growing flashcard deck. To me, that would be a really well-reasoned and educationally supported way to go about integrating that. That might not be what works for everyone, but I think that would be an example. So ultimately, I think what you need to do is figure out how you're going to do this, hopefully embracing some of the spaced repetition and retrieval practice methods that are actually well proven for learning. So you're going to get multiple passes on the content, and you're going to use some foam resources, probably some traditional resources, because I don't think Rosen's or a textbook is going to go away from emergency medicine anytime soon. And you got to figure out what your approach to that is going to be. And again, not something that's going to happen. So I hope that happened for everyone. I hope that's helpful. But really, learning styles are a total myth. That's not a thing. Active learning works, passive learning doesn't. That's kind of the bottom line of the literature. So how are you going to be active in doing that? I could very much, you guys live in Montreal, you guys have subways and stuff, right? Lots of other people drive. Listening to a podcast on a subway might be a great way to integrate some foam content into your life and make sure that you're getting exposed to it. But how are you going to reinforce that? How are you going to tie what you're learning there to what you're learning in training, to what you're covering in Rosen rounds, to what you're covering in rounds that week? That kind of stuff is, I think, where you really start, instead of just spending a lot of time trying to learn, increase the value of your learning so that your stuff is building on it, and you're using both traditional and sort of novel resources. That's the best answer I can have, but it's not going to be the same for everyone.
That was an awesome answer, man.
Thanks, Anton.
Yeah. So yeah, Brent is an expert in this field in terms of how to do that. Those are the great sort of practicalities of how you might do that. I'd like to comment a little bit more sort of philosophically. One point is that I recommend not depending on foam for more than 70% of your learning, which I suspect, and Brent probably has some data to back this up, that might be happening out there. I think it's really important to still read the textbooks. Well, not only read them, as Brent was saying, but actually try and engage in them some way by making cards or something, and read journal articles. I think it's really important. So that's the one thing. And then in terms of how you're going to integrate foam, I think if you step back a bit and you just think about the concept of curiosity. Brent was talking about engagement. The way you're going to engage in your learning is simply always reminding yourself that to be curious. And sometimes, you know, you're tired or you're bored or whatever it is. But if you find a good resource, and the resources that you like, they will be engaging in themselves, or they should be. And I think however you do this, if you can find a way to be curious. So one way to be curious is just to think about a patient that you saw that might have this. That'll kind of force you to be curious about the topic. So curiosity, I think, is one of the most important, just general philosophical concepts in learning, which I think kind of gets forgotten. You know, rather than thinking of your residency as this thing that I have to prod through to get my certificate so I can work, think of everything that you hear or read or participate in as an opportunity to be curious and learn. And I think we kind of forget that sometimes.
Yeah, especially when the fatigue kicks in, curiosity can sometimes wane. But with all this discussion and what was mentioned before about the centralization of foam, I was wondering do you foresee in the future that the centralization could lead to a more peer-reviewed process, somewhat like journals? And I know that there are plenty of residents who I've spoken to who actually prefer both of your guys' content to actually reading the textbook. I'm wondering if in the next maybe decades, do you foresee perhaps a shift in terms of what information becomes core curriculum in residency programs? Will it be alongside textbooks? Do you see maybe textbooks being replaced one day? Like, it sounds like more you're thinking just an amalgamation of all this information is where we're going, but a more official foam.
Yeah, so I mean, I'll note that like the role of textbooks have maintained in my mind is that they are a organized way to kind of look through all of the content in a very standardized way. And that in some ways potentially makes them kind of boring or dry or difficult to, and that's potentially a challenge. When I say centralization, I mean, like, we are going to see, I think, like we see centralization as Anton mentioned, like there's potentially a smaller number of more established foam websites with large followings than there were like 10 years ago. 10 years ago, it was like, there'd be a website up and down. There'd be one would stick around for 5 years, disappear. One would stick around for 3 months and disappear. There was a lot of churn on that. And now there's a lot more established. That's a lot more established. There's also traditional organizations getting into it and having resources. So that centralizes it a little bit more. I really can't honestly see, like, as much as I say that that's a trend, I don't see, okay, the core, your academic half day is going to be taken up by this content online instead. I don't really ever see that happening. Like, there needs to be some local flavor, exposure, community building things that happen like this, where this stuff is done. In terms of peer review, I mean, the peer review of these resources, like we talk about in foam often, when we talk about this, there's pre-pub peer review. That's like kind of the traditional process. Like, you submit it to a journal, they review it, they decide it's good, they publish it. In foam, we see a lot of post-publication peer review happening. Like, if I post something online and a lot of my colleagues disagree about it, I hear about it, whether I hear about it in the comments of the blog post, or I hear about it on Twitter, or I hear about it somewhere else. So there still is some of that happening on a website that is fairly well distributed. The way I see integration happening with core curriculum is not so much in completely replacing something. I do think wikis have a role for covering the whole spectrum. Like, WikiM is honestly a really great resource that covers an amazing amount of content and is kept more up to date than many textbooks. But I still don't necessarily see that as replacing your textbook reading. I think, again, we're going to see more integration where, you might run a session, but maybe some part of half day in the future will be like, hey, I mentioned that iron podcast Anton put in before. It's like a great example of a really comprehensive resource. Like, maybe instead of me going and watching Anton's presentation, stealing all his content, trying to make sure that it's still up to date, and then putting together a lecture on iron, maybe it would be better to say, hey, we're going to cut half day by an hour this week. Your responsibility before you come is to review this journal article and this podcast and have read it. And then my facilitation, instead of giving a lecture, is going to facilitate a really deep discussion and application of that process. I could see that becoming more acceptable. So going away from your job is to present a didactic lecture to your job is to put together a really engaging learning experience that teaches this content really well. And you're welcome to utilize resources from other places. That is sort of how I see those being engaged a little bit more. And then you're kind of reviewing the content as you go in that session, which is a skill in and of itself. So those are more my thoughts about what that could look like in a really savvy program that's using these resources well.
I don't have anything to add there. I only have one question for Brent is, why do you still look like you're 20 years old, man?
I think it's mostly I'm scared to go get a haircut because my wife is having a baby in a month and I can't give anyone COVID. It's the hair.
I might have a follow-up question on that, actually. Yeah. How do you value what's your opinion on having a curriculum in residency in terms that's more focused on oral exam studying and integrate, because you discussed about integrating FOAMed into this, and I thought that was very interesting, but there's so many resources, and the way you need at some point to make sure that you are getting the learning you need on X number of topics. So how would you integrate this curriculum into residency?
So, I mean, just sort of as, and maybe I didn't explain this well enough, but I guess I was kind of thinking about, you guys already have a curriculum for your half days. In Saskatchewan, we use a 2-year curriculum to kind of cover all of the content that we want to, so basically every topic theoretically gets covered in some way, shape, or form in a 2-year cycle. But how you go about covering that information is different, or could be different. Like you can imagine some content being covered in sim, some content being covered in case-based discussion, some content being covered in M&M rounds, and some content being conducted in a didactic lecture. Similarly, I think foam could be integrated into some aspects of those. So that's sort of more how I would see it coming in directly to the classroom, while also knowing that people are accessing these resources externally in support of their learning, either inspired by a case that they saw, something specific they want to learn, or in preparing their own content for these sessions. That I mean, honestly, one of my first go-to, both in the sim world and if I was ever giving a presentation again on a topic I didn't know a lot about, would be to go, yes, to the literature to look for this content, but also to go to the foam world to get some of that content. And historically, I probably would have cited all of the research articles, but not really mentioned some of the foam stuff too much that led to my thinking. But I don't know. I don't think that's changed anymore. If I see a really good resource, educational resource that's really well put together online, I'm going to try and integrate that into my talk, or at least cite that that's where it came from. So those are some of my thoughts. Again, I think that structure is still going to come there from the residency program. And then the resources might shape it differently.
Yeah, when we're preparing for an EM Cases podcast, we draw from both foam and traditional resources. One just little practical tip for people who are preparing presentations, the TRIP database is a great place that has both foam and traditional resource citations on it. And then foam search, it's basically like a Google search for foam. They're two great resources if you're looking for material on particular topics, if you're preparing any particular topic for a presentation, or if you're just studying, actually.
Awesome. Any other questions from the crowd? There were a few other, there are some links being put up right now, which is great. Oh, sorry, I'm just, so Dr. Coombs is wondering if I believe if the content is affected by whether or not you have cases that reflect that topic often or very rarely.
Sorry, could you just repeat the question? I didn't get that.
Yeah, so I believe the question is, in terms of the content that you post, is it affected by the frequency with which you see these cases? So whether it be a lot or a little in your practice, does that affect what information you decide to cover next?
Oh, the timing of the repetition. Oh, I see. So in terms of how often you're reviewing, or like what the ideal, I think one of the questions was related to how close in time space. That's referencing back to that spaced repetition, how often it needs to be repeated. So to me, there isn't an ideal time, and probably the time between the review that you're going to need to do is going to depend upon how well you knew the topic before, what type of learning that you did before, whether it was very passive, whether it was very active, and things like how long you're seeing this in real life. So for example, if I go and read a chapter on asthma treatment, and I have a case on asthma treatment the next day, and I've reviewed a podcast on it, and and you see it all the time in my practice, I'm probably not going to review that very often. I quit doing peds. Like, I don't do peds emergency specifically. We have a peds department, peds emergency department now. I'm like, oh my, you give me a kid now at one of our community sites, and I'm like, okay, bronchiolitis. I'm pretty sure nothing still works, but I'm not sure anymore because I never see that. Croup. Do I go 0.3? Do I go 0.6? Has it ever mattered? I don't know. But these are some of the questions now that trip me up because I never see those things, and I need to review them more often in a different way. And in the management, honestly, they become harder. But when I do review them, I learn more from them. So ultimately, like, and honestly, like, I really think it depends on you and where you're at with that topic, and what you've done to learn about it before and how comfortable you are with it. Bottom line is, the more you see things, the more comfortable you are with those things, the more you apply them in your actual practice. I think it's very much likely that you're going to need to review those less frequently or almost at all. Like I mentioned that for peds, I'm like that uncomfortable. I do trauma as part of my regular practice. Like I do trauma weeks on the ward, I do trauma where I see it. You want to ask me trauma questions? Like, I don't need to review those at all. I see those all the time. I look them up, look up little things occasionally, but I'm so much more comfortable. So my spaced repetition happens in my clinical practice where it doesn't happen in my pediatric practice. So the way I need to review and look at those topics changes. I guess that would be my action of that. So, but I don't think you're going to find an ideal perfect, this is the length of time you need to review. Some of the flashcard apps that you can get now are amazing because they build in spaced repetition for you. I know the one that I used when I was in training, it was like I know this really well, swipe up. I know this sort of well, swipe right. I know this not at all, swipe down. And that determined how fast it would again show me that flashcard. That's the kind of stuff that you can sort of titrate that yourself in terms of how long you're going between reviewing content, as an example.
I agree with everything Brent just said. If there's going to be a magic number, I think it's similar to exercise. And if you stop, if you run every day and then you suddenly stop, it's about 9 days, they say, before you kind of lose everything and have to start again. So if there is a magic number, it's 9 days. But I agree with Brent. There's so many factors, and it totally depends on the topic and how familiar you are with the topic, how rare the topic is. I think, again, it really comes back to, on a more philosophical level, it's just curiosity. If you're in the emergency department and it looks like there's an interesting case somewhere happening in your department, go and find out what that is. And then if that's an interesting case on something you haven't reviewed recently, then go and review it.
All right, great. I am cognizant of the time for you guys. This has been a pleasure. So I think I might limit it to one more question before we call it a day, if anyone has one.
I just want to call it, just in response to this comment on about the creation of resources and creation of sim cases and stuff. The one thing I think maybe that got lost in my discussion of like how we went through this and stuff and how we can use all these great resources is there's a taxonomy in education called Bloom's taxonomy. And it basically kind of increases the level of activeness of your learning that happens to the top to the bottom of the pyramid. If you Google it, you'll get a picture of the different things. And the bottom line is creating and putting together things is like the most active possible way that you can learn, and probably the best way to learn. And I think something that I benefited from in my training when I was doing this blogging that I did was I was creating a lot of educational content and resources myself. And that was probably the best way for me to learn about a topic. Anton, I'm sure when you put together a podcast, you know more about that topic right after you've done that podcast, and are probably better able to speak to it than you would be at any other time before. And there is still, I think, some value to doing that type of work, because it is very high level and you get a lot out of it.
So just a last little philosophical comment, just jumping off of what Brent just said, is about creativity. And that is, in our clinical practice, there is pretty much zero creativity involved in our clinical practice. And one of the things that I found personally about producing foam is that it's an opportunity to be creative. And I think there's actually some literature to back this up, that in terms of life satisfaction, doing something that's creative will help you be more satisfied in life. It could be something as simple as cooking a creative meal, or basket weaving, or whatever it is. But the nice thing about foam is that it allows you to be creative within your job. And so if you can integrate some creativity into your job, then your career just becomes more satisfying overall, I believe.
That sounds like a perfect way to close out our discussion here. So this has been great. Thank you both so much for being here today. Can't thank you enough. Hopefully we'll hear from you again at some point in the future.
Yeah, thank you so much.
Thanks for having us, guys. This is really fun.
A privilege and an honor. Thank you, guys.
Well, it's privilege is all ours. So thank you. Okay, so for those of us here, it's been a great day, great morning, and we have RPC coming up in 4 minutes. So we'll take a quick break here, and hopefully we'll see as many of you as possible out at RPC. So thanks, everybody.
Oh, and just next week is a research day, which will be held on the Friday, which means that there's no formal rounds on Wednesday, but all residents are formally welcome and forcibly invited to come on Friday. We'll let you know once the schedule is out. Jay? Oh, Jake's gone.